Well, good morning. Dobro utro. It's great. The first thing really worked. You were earlier than expected. Well, my name, you see that, is Dieter Wieck, and currently I'm chairman of the Standing Committee of PARE, and I welcome you to our 19th EULAR Annual European Conference. I'm happy to say, well, I welcome you, but there are lots, I hope, joining us online from Bulgaria and around the world. We have a very full program, and all you know how it starts. It starts with some housekeeping rules. You already saw that. There is a simultaneous translation available for all sessions and workshops taking place in this room. So please use channel 1 if you need translation from English to Bulgarian, and channel 2 for Bulgarian to English. We are live streaming all plenary sessions and selected workshops, both in English and Bulgarian. So if you indicated that you do not want to appear in the live streaming, well, please sit in the area at the back of the room, which is out of line of the camera. The workshop we will be live streaming today is workshop 3. That's the workshop on patient education and increasing awareness of comorbidity. Tomorrow we will be live streaming 2 workshops. Workshop 6A, that's the first young PARE workshop on facilitating transition in young people, and workshop 7B, the second workshop on improving communications between patients and their healthcare team. So if you're in one of the workshops being live streamed, which will be taking place here in Musala, please let the workshop leader know that you do not want your image shown. I don't know, is there anybody who doesn't want to be seen? No, well, great, fantastic. Why am I telling that? Okay, fire exits. I hope this will not happen, but right, left, those are the fire exits. Toilets, in case you haven't found them yet, just leave, past the elevator, turn right, and then you'll see the toilets on the left. Put your mobile phones, please, on silent, or turn them off if you do not use your mobile to Twitter. You see this clock, and so be in time so that we really can start promptly. Last year we introduced that. Twitter. There's no Twitter wall here in this room. So if you would like to join us on Twitter, please do so. See how many people you can get to follow you. There are 2 people really in charge of that. One is a very experienced EULAR person from PARE as well, Florian Klett, on my left, and then there's Macarena over there, our communication manager. Florian, a few words about Twitter? You've got a mic.
Thank you, Dieter, and welcome everybody. Also, welcome the Twitter community. I can really say that the excitement grows, and we've already had 500 posts on our social media wall that is you can see outside. And I will be updating you on any latest statistics, and if there's really something urgent that would be feeding into the discussion, I will also try to raise them.
Yeah.
Thank you.
Thank you very much for that. You've all got that fantastic workbook. So the first thing, well, put down your name, write down your name. It's very helpful in case it gets lost. But it is also a great help. I don't know whether you just went through that workbook. It is a great help because there's a lot of information. You can put down your notes. And these are things you will need later on, I think, if you reflect on what happened over here. And also later, you know, we're going to have a survey right after this conference and 6 months later, because we would like that you, well, show what you did with all these things you learned over here and how you perhaps implement that in your organization. Another thing that should have been in the workbook or was given to you, you've got these voting cards, and well, I lost my cards last year, so please do not do so because you will need these cards, and there will be some voting. You'll see that, and you need these 3 cards. Well, our theme is patient-centered care. We've always got a theme for 2 years. This is our theme for 2015 and 2016. What is patient-centered care? Well, it means the patient is informed, respected, involved in his or her care, and the person's wishes are honored during the healthcare journey that normally takes quite long. It is our wish that patient-centered care replaces the very often still existing physician-centered system. A large part of patient-centered care is shared decision-making. That is, the conversation that takes place between a patient, the doctor, and the members of that healthcare team, or the professional team. The aim of this discussion is to reach a healthcare choice together, where everyone understands what is important to the other person when choosing a treatment. Shared decision-making is a process in which both patient and health professional make a decision that takes into account the best evidence of available treatment options and the patient's values and preferences. Patient-centered care and shared decision-making are important factors for a person's satisfaction in spite of this lifelong illness, and what I really believe is that this will enable better outcomes. Professor Gerd Burmeister, President of EULAR, will be talking about shared decision-making later on in his keynote presentation. A number of workshops as well will be covering aspects of patient education, good communication, and the benefits of shared decision-making. I already mentioned the workbook you've got, and there are lots of details in there. There's also the program, so I do not want to enlarge on that. This is what you know how conferences work. You invite lots of people, and you also feel that you invite those people who are important and where you can really transport your message. This also happened, the Bulgarian Organisation invited the Bulgarian Minister of Health, Dr. Peter Moskov, but he can't come. But he sent a letter, a short letter, and we thought it would be adequate that this letter is read out, and this will be done by Bojana Boteva. Bojana.
Welcome to everybody. I just want to read the letter from our Ministry of Health. It is in Bulgarian, that's why I'm going to read it in Bulgarian. Уважаеми дами и господа.
Distinguished ladies and gentlemen, it is my pleasure to congratulate the organizers of the 19th Annual Conference of PARE and on the topic patient-centered care. Let me send my sincerest wishes for successful work. I believe that the deliberations during the conference will contribute to finding the best and forward-looking solutions for improving the treatment, prevention, and rehabilitation, and to reducing the burden both on the individual and the society. I am convinced that the discussions will deliver answers to a number of important questions related to the logistical and conceptual aspects of rheumatism as a disease and a social phenomena. I wish success to and fruitful work to everyone. Dr. Peter Moskov, Minister of Health.
Bojana, thank you very much. I'd like to welcome Professor Gerd Burmester. Professor Gerd Burmester is the president of EULAR. He is professor of medicine in the department, I hope now it's right, everything, because it's a very long title, in the Department of Rheumatology and Immunology at the Charité University Hospital, Free University, and Humboldt University of Berlin. He is a very, very busy person, traveling around the world. And what I found strange sometimes, I tried to contact him, and then, well, he sent an email almost at once, and then it said, well, greetings from South Korea, greetings from I don't know where. So it is a fantastic job he's doing, and it's great that he really took time to come to this conference. Thank you very much for that. And please welcome Professor Gerd Burmester.
So good morning, everybody. It's a pleasure for me to welcome you all to this beautiful area of Europe. I've never been here, but I was quite impressed that there's still snow on the mountains, and it's a beautiful location. We are right in here. And as Dieter said, I'm a pretty busy person, but not because I like to travel, which sometimes I do, but EULAR, of course, is a very important league against rheumatism, so we are invited to our South American and Central American friends. So I just came back from Panama, not attending to any letterbox companies, I must say, but to the panel meeting, which was quite nice, informing our colleagues from Central and South America about rheumatology. And I'm nearly on my way to go to Japan to meet our Japanese colleagues. And I think these interactions, of course, are very important, not only, of course, for the physicians, but for the patients as well. And I think this conference is a very, very nice document how currently and also in the future patients will be involved in their own care and how to set the recommendations and how to bring rheumatology forward. And with these words, I would like to especially thank Dieter for being a major part of the organization, of course, the two vice presidents of EULAR, Marius and Christina, and also the staff from EULAR. We have Birte, Florian, and Macarena among us, and of course our hosts from Bulgaria. And I'd like to thank you very much also for hosting us in this beautiful location. So all in all, we have 120 participants from 38 countries, which is quite impressive, and there may be even more in the live stream. And I would also like to welcome the live stream guests. And of course, it is also very important that EULAR documents the support for BOPRD, which is the Bulgarian patient organization for rheumatic diseases. And this is also always extremely important because without the patients, also sufficient nothing. So we are a team, and we need to support each other to also get the best possible care, but also get recognition among the other disciplines of medicine. That is very important because sometimes we as rheumatologists and people taking care of musculoskeletal and rheumatic diseases, we struggle against other disciplines, think they are more important than we are, which I doubt. I always ask my patients, which is the most important organ? What do you think? Well, it's actually the musculoskeletal system. Because it's not the brain, it's not the heart, like the neurologist would think, the cardiologist, no, it's the musculoskeletal system. Because if we can't move, we will not be able to get any food. And if we cannot flee away from our enemies, we would be dead. So therefore, it's very easy that this is the most important system, and this is also documented, of course, by the importance and the burden of rheumatic diseases, which we will also address. And that brings me to the point you may ask, well, how did I personally go into rheumatology? And it's quite interesting. It's an interesting journey that I took because I studied medicine because I wanted to become a psychiatrist. So I was really interested in psychiatry, psychosomatic diseases, the interface between the organ system and the brain. That was my interest. But in order to work on this in medical school, you usually do a medical thesis. And the medical thesis themes were not too appealing, both in psychiatry and also psychosomatic medicine. So I was a little bit depressed that I wouldn't be able to work in this area. And then I went to a lecture, and there was a patient being presented by the lecturer, and this patient had ankylosing spondylitis and was no longer able to play football. And that was the patient complained a lot about not being able to play football anymore. That was his greatest hobby. And I'm an addicted football fan. So I'm a little bit depressed today that Borussia Dortmund lost at the very last minute against a highly esteemed team like Liverpool. So I was said, well, this patient can no longer play football. We need to do something against it. I must go into that discipline to help people with rheumatic and musculoskeletal diseases. I made this decision, and I was lucky to find a very good mentor, actually Jochen Kallen, who also was president of EULAR. And he introduced me into immunology, into the background of rheumatic diseases. That's how I got into rheumatology, and I must say I haven't regretted it at all. Especially now that we also know that there is quite an interface between psychiatry, thinking, how to cope with diseases, and the musculoskeletal system. I think this is a very, very exciting area, and I'm also very glad that nowadays we can help these patients with ankylosing spondylitis. Actually, I take care personally of some patients who are very active in sports, who even play in the Premier League of the German football, and who are ice hockey players with this disease. Something we would have never dreamt of many years ago. But now it's possible. You can lead a normal life if everything goes well with treatment and so on. So that brings us to the extreme and exciting progress that we have made, not only in diagnosis, but also in the treatment. Nevertheless, there are many, many unmet needs, so we need to work hard and address these unmet needs. And also we are not challenged, luckily, I must say, with a lot of treatment options that we can offer to many of our patients. And of course, then the patient is in the center of our care, which for me is also quite easy to envision, because many of you know that I am married to a nurse. So I have daily contact with a health professional. And so we can discuss how to deal with patients, how to integrate patient care. And so it's a very, very important part nowadays. So patients care, of course, also needs shared decision making. which is a very nice English word. It's great, the English language is so great. In German, this is, you won't believe it, partizipative Entscheidungsfindung. Very difficult to pronounce, even for me. So, shared decision making, this is very nice, and sounds very good, but it is not so easy. Let's say nowadays we are faced with maybe 9 treatment options for a patient. How do you make the decision? Even for a physician, it's not so easy. And for the patient, of course, it's not easy either. So they need to be informed. So I think the decisive tool would be appropriate decision aids that tell the patients and also the physicians, these are the options and these you can use in order to make the most appropriate decision. And that's what we need to work on. And in order to address many of these educational needs, we will launch in London at our annual meeting the EULAR School of Rheumatology. Some of you may have heard about it, and we will officially launch this. And of course, the patients and the health professionals, along with the physicians, will form an integral part of this school. So the patients will have their own classroom. And that is something we will discuss. The classroom is not completely empty, but we need more educational material, of course, for the classrooms, especially decision aids informing us about the diseases, the treatment options, the management, and other factors, because then the best possible care is delivered. So with these words, I'm quite excited about this conference, and I'm very glad that you gave me the opportunity to join you all here. And of course, I would like to thank you very much, because EULAR highly appreciates your daily input into EULAR. Because EULAR is a unique organization. I just came from PANLAR, and this is the Pan American Association, and I will join the Japanese colleagues and also the Asian colleagues in the PANLAR meeting in Shanghai. But I think EULAR is the prime example where the patients, along with the health professionals and the physicians, are an important pillar. I think this is a huge and tremendous opportunity, and we're envied actually by the other leagues in the world that we have this opportunity. However, it would not work without your input. And I realize, and we have been discussing this quite frequently, that in order to get here, many of you have to take vacation, you have to be off from work, from family, you have to work hard, you have to fill in your workbooks, as I noticed, and work in the workshops and so on. So this is really a lot of voluntary work that you are devoting to EULAR. And EULAR really highly appreciates this and is extremely grateful, not only to you sitting here, but to everyone being involved in the EULAR affairs. And with these thanks, I like to again wish you all us all a very successful conference. I'm pretty excited, I must say. At least the preparation, and I'm sure the workshop itself, is extremely well organized. I would be happy if all the scientific events would be organized so well like this one here. And so again, thank you all. And again, I wish you a very successful conference. Thank you very much for coming here.
Yes, thank you very much, Professor Gerd Burmester. I would like to see that more young German doctors have got this fundamental experience with the footballer, because, and this is what Gerd Burmester knows much better than I do, we really lack rheumatologists in our country. Perhaps you as well in your country, or your countries. And this is really a key issue for us, having more rheumatologists. I'd like to introduce Bojana Boteva. You already saw her. Bojana is the vice president of the Bulgarian Organisation for patients with rheumatic diseases, a key member of this task force, a PARE board member as well. And Bojana, I'd like to listen to you.
Thank you, Dieter, for this kind introduction. I want to thank first to Professor Burmester for being here. I know that he's quite busy, so thank you very much for being here. So, dear all, dear delegates, dear Dieter, dear Professor Vladeva, dear Associate Professor Ivkov, dear Professor Burmester, as the Vice President of Bulgarian Organization for People with Rheumatic Diseases, I can say that it's a great honor for us to host the 19th Annual Conference of PARE here in Sofia. The Bulgarian Organization for People with Rheumatic Diseases is a young organization, and being part of PARE is very important for us because we are able to learn from the best, from very experienced countries, to gain knowledge and to be inspired to develop our organization further. In fact, I can say that I haven't ever dreamed that we will host that conference, and I want to thank EULAR and PARE for choosing Bulgaria as a host. Looking back 5 years ago, when we established our organization, I can say that there was a lack of information about rheumatic diseases, about treatment, rehabilitation, and whatever you can imagine. Today, the situation is a little bit different. I can say better, and I can say that it is because of our efforts, of course, of the efforts of our partners from other patient organizations in the field of rheumatic diseases. So I believe that such conferences are very important and have significant role in educating national patient organizations, empower people, not only the board members, but of course the members of the organization. We are doing our best to promote rheumatic diseases among general public, among society, among our members, family, and so on. And such conference is quite important, supporting our efforts. I do believe that only when patients, patient organization, rheumatologists, and health professionals work together, also the institutions, I forgot them, what a pity, it is possible to establish the patient-centered care model, and why not to say person-centered care model. So I would like to thank all of you for being here. I want to thank the EULAR Secretariat who were so kind in helping us when we prepared this conference. I can assure you that it was really hard, but with their support it was more easier. I want to thank all members of our organization, all people who supported us during the years, and I wish you a successful conference and pleasant stay in Sofia. And you can see the members of our organization, most of them are wearing green t-shirts. So if you have some questions for whatever you want, you can address them. So thank you very much for being here and have a successful conference.
Yes, thank you very much, Bojana. Our next speaker is Professor Stoyanka Vladeva. She is a professor for rheumatology at the Department of Internal Medicine, and she will give a welcome on behalf of the Bulgarian Society of Rheumatology. So please welcome Professor Vladeva.
Dear EULAR and PARE leadership, dear delegates, representing the Bulgarian Society for Rheumatology, I'd like to thank EULAR for choosing Sofia to host this year's conference to PARE. This is the biggest forum ever organized by EULAR in Bulgaria. Our country is small in terms of size and economics, but the problems with care of the patients with rheumatic diseases are important. Bulgarian rheumatologists are seeking the best diagnosing and treatment of their patient with professionalism and support, although encountering many difficulties considering the complex socio-political situation and many other factors in the country. The expectations for our patients are great, and they deserve to receive comprehensive care with a force to incorporate all necessary resources. The active cooperation with the patients' organization will increase their influence in the health system and give the chance for changes their favor. Back to 2006, 5 principles were defined by the International Alliance of Patient Organization in order for the patient to be in the center of the health care. Respect, choice and decision, access and support, information and inclusion of the patients in the health politics. These principles are still valid now, and sticking to them will optimize the practice and behavior of politicians, health professionals and industry related to the health care. A Bulgarian nation has chosen for its national motto the phrase "Unity make strength, Concordia res parve crescunt," and believe in it. Let this conference make all of you stronger and more confident. We all together, patients, doctors and society, and achieve prevention, early detection, treatment, and stopping the rheumatic disease. I'd like to wish you all of success in this historical for the Bulgarian Rheumatology Forum. Good luck.
Yes, thank you very much. Our next speaker is Associate Professor Ivkov, and I was very lucky because yesterday evening we had the chance to talk together. Professor Ivkov is Vice President of the Bulgarian Organisation, Patient Organisation. He has for many years championed the cause of disabilities in Bulgaria. And he has written a lot about many issues affecting people with chronic diseases and disabilities. And yesterday evening when we talked, we saw, well, there are lots of differences between Germany and Bulgaria. Certainly, the health system is different, for example. But there are some things, it doesn't matter how advanced the country is, this is still unbelievable. That is, what are things really accessible, wheelchair accessible? And we found several parallels where patient organizations and representatives are really fighting to improve the situation And I don't know whether you found out that in your country as well. It takes sometimes years till things really change. But nevertheless, we do not give up. So please welcome Professor Ivkov.
Уважаеми професор Бурместър, уважаеми господин Вик, уважаеми
Professor Burmester, Mr. Dick, dear delegates, dear friends, allow me to briefly introduce to you the activities of our organization as well as opportunities to implement the patient-centered care model. In the late autumn of 2010, a group of enthusiasts got together and set up the organizations of patients with rheumatological diseases in Bulgaria. We have a chairperson, 2 deputies, and 2 secretaries. I would like to underscore this because there are few organizations like this in the world of patient organizations. All of our members and the members of our leadership are all volunteers. Nobody's on the payroll of the organization. The personal goals of these young people have become the goals of the organization itself, led by the motto that knowledge is power. They are working on enabling their members and target groups by providing them information on how to better manage one's disease and, if possible, improve the conditions for diagnosis and treatment. They work on expanding the opportunities for inclusion of people with RMDs and to provide them with different social services, such as providing advice, education, and sometimes even charitable donations. One of the leading goals of our organizations is international. Through our affiliations with EULAR, our patient organization is able to provide timely, up-to-date, and understandable for the patient information. And thanks to this arrangement, we became the first Bulgarian organizations to put forward the model of patient-centered care and launch it to the public. We chose this because there are 2 pillars which, in our opinion, are not visible in Bulgaria. You can see it on the slides. On the one hand, it is the link and partnership between the patient families and healthcare providers, and on the other hand, the values of the patients. This is indeed a model of a holistic approach to diagnosis and treatment for people with RMDs. And since, at least in the health policies that we see in this country, this holistic approach is not present. We, as an organization, have focused in the past 2 years or so on public awareness. We launched different campaigns. One of them in 2015 was entitled "We Are Not Made of Wood." We launched it in the 14th of October with a press conference to shed light on the problems of people with RMDs in accessing relevant medicine products. Anea and Borana were very precise when they disclosed the social implications of the fact that a certain patient has an RMD, and this chair, the chair of pain, became the symbol of the pain with which people with RMD go through life. When we present a model, regardless of what exactly the model might be, it is a model that we want to implement within social environment. So what is the context in Bulgaria, and does that provide conditions for the implementation of this model? Unfortunately, my answer to this question in the context of Bulgaria would be no. No, this model cannot be implemented in this country at this time. There are many arguments that I could use to justify my opinion, but I will only give you a few. In the constitution of this country, healthcare is defined as free of charge, accessible, and of the highest possible quality. All of this is then translated into law. Unfortunately, at this time, however, healthcare is extremely expensive, very difficult to get access to, and almost no guarantees as to quality are provided. Patients and very often doctors as well are faced with the problem that all practices and policies are focused on cutting costs for a given medical service, which means that care is pushed far out into the background. And many times people will just give up the use of health services because they decide that buying food put on the table is more important. In other words, medical treatment, medical care is becoming smaller and smaller. Another point, the cost of health that out of pocket for the patient is going up all the time, and this can be seen in many surveys. Now, in terms of the partnership or relationship between doctors and patients, the prevailing approach is paternalistic, where the doctor is the omniscient God and the patient knows nothing and can do nothing, a small child. And then we can see a conflict of interpretation in what doctors understand when they use the term disease and when patients feel in terms of disease. There are also other complications due to the market, the fact that healthcare and medicine have become markets. The patient was, is, and will be a patient, while Bulgarian doctors have become actually business people, and hospitals have become commercial entities. And the way in which healthcare is provided reminds one of the history books on the birth of capitalism back in the 18th century. And this model cannot be fully blamed on others without the patients sharing in this, because it's much easier to just give up all responsibility and expect that someone else will take care of you and will make the decisions for you. But hopefully, through our efforts, this is going to change. You know that this world movement of patients is led by the motto, nothing about us without us. Unfortunately, in this country, all policies, social or economic, is somewhat inverted. And it says all about us without us, or all about them without them. They know what we need better than ourselves, so they will take care of the decisions and the provision. This makes it very important to realize that when the patient doesn't have the sense of ownership but is excluded from the decision-making concerning his or her own health, we can only expect serious problems in the trust relationship between doctors and patients. And if there is no trust and confidence, you have already undermined the treatment itself. These slides show some of the events that we have carried out in this conflict with the institutions, that unfortunately is not a dialogue, because there is no response on their part. They never listen. I'm trying to find two quotations which I wanted to show to you, but somehow I can't hit on them. But they are very indicative of what should but is not happening in Bulgaria. The first one is a quote from a scientific review. A doctor addresses politicians in the US saying, our politicians should not implement market principles in the area of healthcare. Healthcare should be spared from the volatility of market arrangements. This is completely the opposite of what we see in Bulgaria. The second quotation is from Peter Klimek, the wonderful writer, who says in one of his novels, I have nothing against healthcare with reasonable costs. However, I'm firmly against cost determining the development of healthcare. So this is what we have in this country, this undesirable situation. Unfortunately, in policy making in healthcare in this country, the needs of patients are almost completely disregarded. May I put in parentheses a clarification that the reform in healthcare in this country was started by doctors. It is designed with doctors in mind, and then the lawyers and the legal professionals joined in, and as a result, it's a complete chaos and no mention of the patient. There are thousands of pages and hundreds of changes and amendments. Now, these are some of our efforts to get the Bulgarian institutions to give us some attention and to listen to us. We are carrying this chair of pain and offering people in the various institutions, the Council of Ministers and so on, offering them to try it out. This initiative, this campaign, was concluded at the end of October, where we gave that chair of pain as a gift to the National health insurance fund. This is our only insurance fund. It's like Voltaire and God. We do meet, we say hello, but we don't really talk. So it is a difficult dialogue indeed. And unfortunately, without dialogue, I don't really see how we could implement the patient-centered care model. This is not the only campaign that we have carried out. There's been quite a few of them. And I must say that most of our events are quite aggressive, and we are proud of that because the government institutions cannot afford not to notice us. Every opinion that we have presented on the various issues is based on a very thorough analysis of most recent developments, because we keep an eye on the developments in legislation and newest practices, as well as the newest achievements in the area of rheumatology. So these are not just stories of people who need a shoulder to cry on. Unfortunately, so far, despite of all of our efforts, we cannot boast with a lot of success. Still, we're optimists, especially through the optimism of Boriana and Sneža, who are really hard workers and very positive. I'm very proud that I know these two young women, and they are really delightful co-workers. So we often say that the spirit of law is recognized and respected when it becomes the law of the spirit. The motto that we are discussing is like law. It must be realized and accepted so that it can naturally be implemented. And this, as we know, depends on the efforts and good will of doctors, patients, and institutions. The famous Russian scholar Vladimir Bekhterev, and he was also a physician, once said that if after consultation with a doctor the patient doesn't feel better, it's not good for the doctor. The humanistic approach in this brief quote must permeate our laws, our policies, all of our actions, so that we can indeed implement an adequate model where the patient is indeed in the center, a holistic approach where the patient will be seen first and foremost as a human being and not as a diagnosis or a pathology. We would like to believe, and we do believe, that this model will sooner or later be implemented in this country as well, hopefully sooner than later. Thank you, and I will gladly take your questions later on.
Yes, Professor Ivkov, that was very impressive. Well, to get to know more about the healthcare system in Bulgaria, how you see the patient-doctor relationship, what your organization is doing to empower patients, and also, well, to see, well, what you're trying to do with your campaigns to improve the situation and to lobby, really. So first thing, we are rather early. I do not know whether this happened before, not what I experienced. We are so fast. So first thing, I'd like to to give you the opportunity. Are there questions? And you may ask Professor Ivkov. I do not know if it works technically. Anybody who'd like to know anything about the Bulgarian healthcare system or the organization and so on? Is there anybody? No, seemingly not. But I'm sure you've got questions, but perhaps they will come up later on. But we've got another fellow here, and I'm sure he has got something about either, let's say, the presentation we just heard, or perhaps the first tweets that appeared. Florian? So, sorry, Professor Ivkov, thank you very much. Perhaps people will come up later on and ask you things in the break that we will have soon. Oh, yes, yeah, Professor.
Yes, I have a question. How is the interaction in Bulgaria between physicians and patient organization? Is there, because normally we are most successful if we fight jointly together.
Yes, Professor Burmester, you are absolutely right. Unfortunately, our communication with the Organization of Rheumatologists is very difficult, and the most recent meetings which I attended saw this maximum which I mentioned, everything about them without them. I didn't feel any attitude of partnership, at least myself. There are many doctors who are open-hearted, open-minded, and they work with patients. We have one of them among us, Professor Vladeva, but this is not enough. The dialogue must occur at the level of organization, and it is very difficult for us to find this common language.
I'd like the Bulgarian rheumatologists keep the Hippocratic oath and follow and implement any new methods and recommendation for rheumatology thanks to the EULAR. In times of severe crisis, we certainly give more than our patient and strive to treat both the patient and the person. But ultimately, we are not magicians when they're not finding for diagnosis and treatment. I'd want that second Global Congress of Patient Organization in 2006 in Barcelona for the first time defined the necessary for putting the patient with chronic disease in center of care, and the goal today is local, regional, national and international level to represent and support the interests of patients, their family, and all professionals who care them. In Bulgaria, there are such structures that have the powers, duty, and capacity to help and organize on behalf of the state the care of patients with rheumatic disease. These structures are called regional health inspections. They have the capacity of people, tools and resources to put the patient in the center of care and to unite all of youth involved in the process. I suggest, especially for Bulgaria, by the initiative of Bulgarian Organisation of People with Rheumatic Disease, to set up in every major city a structure called, for example, Rheumatic Care Group, including representative from, of the organization, one rheumatology expert, and a representative from the National Health Inspection. It may sound difficult, but is not. But it is only correct and effective approach. This is my opinion from Association of Against Osteoporosis.
Yes, thank you very much. I can see there are two more questions from the floor. Could you please say your name, where you're from? It helps us a little. So thank you very much. One over there, and then afterwards there's Yolanda in the back. Okay.
My name's Raj Mahapatra, and I'm from the National Ankylosing Spondylitis Society for the UK. I was wondering what sort of support the patient organisations have here in Bulgaria from pharmaceutical companies.
The support which we receive, at least for our organization, is based on one single thing. When we prepare a project or an initiative which goes on over time, we try to find funding in order to implement this activity or initiative. That's it.
Yolanda?
Yolanda Algierska from Poland. I have two very short questions. I would like to thank you, Professor Ivko, for your interesting presentation and for new ideas for my organization. And the first question is, do you need a referral from family doctor to rheumatologist? Is the first one. And another one, who take care of you after diagnosis, family doctor or rheumatologist?
Thank you for these questions. Most often, the first physician to see a person with rheumatic disease, this is the family doctor. This is a normal case. Unfortunately, their reaction is not adequate in many cases. They decide that their task is to decide that it's a rheumatic case and the referral should be to a rheumatologist. However, very often the referral is to a neurologist, to an orthopedician, and that takes time. The rheumatological disease starts doing its evil job while the person is treated among departments and he doesn't know what his diagnosis is. Unfortunately, one of the major problems in Bulgaria is quick diagnosis and implementation of proper therapy.
If I remember, the Irish had probably last year in the middle. Just your name, please. And
thank you. I'm Sinead Frawley from Arthritis Ireland. I'm just wondering in relation to access to biologics in Bulgaria, does the government or the National Healthcare Service subsidise the cost of biologics for patients, or do patients have to pay the full costs? You know, they're very expensive.
This is a very painful question. I think across Europe or in most countries, the situation in Bulgaria as of today is 75% of the price of biologic is reimbursed by the National Health Insurance Fund. The remaining 25% are still covered by importers, by the companies who import the biologics. Unfortunately, policy in this area is to consistently limit the access and limit the number of people treated with this modern treatment. Even we spoke with Boriana, these practices and policies, with these practices, we have 2 or 3 cases this week where people, where doctors refuse to put rheumatologic patients out there. They refuse to enter them in the necessary record, which prevents them from getting treatment. And if they are to receive biologic, they should be registered as people with disabilities. But this is other activity. I'm Dr. Angelova. I'm director of the National Rehabilitation Hospitals, and I'm president of the Association of Doctors for Rehabilitation Medicine. I think we are a good example of good cooperation with patient organizations of rheumatic patients. Rehabilitation is regulated in our country, but it is not long enough in order to be efficient. We know that the final stage of the treatment of each patient is rehabilitation. Bulgaria has a national complex for rehabilitation, a group of hospitals, but unfortunately, patients with BOPRD, they can receive only 7 days of rehabilitation. With some other complications, they may get further 7 days. But I believe that for 5 or 4 years, we have had good collaboration. And my recommendation to the rheumatologists and to patient associations is to join our efforts in order to introduce a clinical path of at least 14 days. The mother of Dr. Angelova was my doctor. She was an exceptional person. I used to talk to her for hours, not only to discuss treatment, but also on what would be the implications of some drugs. That was at the time when I didn't have children, when I was a student. She and her colleagues in the 1980s said specifically about BOPRD disease. The classical treatment is sanatorium treatment 2 times in the year, 20 days in the spring and in autumn. And as Professor Angelova said, we have just 7 days according to our rules.
Questions? One, and then Christina, and then, okay, and then the man at the back, and then Florian with recounting the tweets. Okay, you.
From the national radio, do we have sufficient number of rheumatologists in Bulgaria? Are there any areas in the country which are not covered by a rheumatologist, and how people do it there? You see, we do not have enough rheumatologists. To my memory, there are between 80 and 100. In some areas, there is not a single doctor rheumatologist, so people have to travel around to the nearest one. Unfortunately, these are the facts. Which are these areas? The districts of Kърджали, Ямбол, Хасково, Силистра, Blagoevgrad, and perhaps some more. I do not have information about the others.
I'm Vice President of EULAR, representing health professionals. And I certainly appreciate the important role of rheumatologists, but I have, of course, a question about health professionals in Bulgaria. Do they have the independence and the power to support patient organizations such as yours and apply a more person-centered care than you report about rheumatologists?
Of course, no one can prevent such collaborations from happening, but it appears to me that the fundamental philosophy of this model, this holistic base, this comprehensiveness of the approach, this patient-centered philosophy is lacking. It's lacking in many places. There are very, very few doctors, such as Professor Vladova Andreeva, who approach and see the patient first as a human being. And only then, as I say, I have hundreds of social roles, and one of the last roles is a person having Bechterev's disease. I do not use the term patient. I'm not a patient. I'm a human being. I'm a patient only in the doctor's office. Outside the doctor's office, I'm a human being. No problem for this collaboration. Yes, we have very severe criticism to rheumatologists, to the government, and to everyone, to ourselves. We are just starting. We are trying to do as little mistakes as possible. There is an organization of healthcare professionals. We can't contact them. We don't know, is it there or isn't. Sometimes we live in a dark forest, and we don't know sometimes whether the forest ends after this tree or it doesn't.
Peter Gershak from Slovenia. I would like to know how many patients with rheumatic diseases has biological treatment in Bulgaria.
If memory does not mislead me, it's about 4,200. According to statistics from our rheumatologists, only people with rheumatoid arthritis, Bechterew, and some more similar diseases are more than 100,000. That is the percentage of persons receiving biological treatment is very negligible.
Professor Ivkov, sorry, I just said that to be in time. Florian, what about people outside of the room, or perhaps even inside of the room? What about the tweets? What are they about?
I think it's become clear that this subject is really close to everybody, and a lot of people have echoed the voices already shared here. I think it's important to note that a discussion has taken place, or is taking place, about what is good centered care, patient-centered care, and it's when asked what is important to you in the management of and treatment of your disease, and what are your personal goals, which means not only to include treatment options, but also to include the whole person, education, social and individual goals. And what Professor Dr. Ivkov said, it's needed to have a humanistic approach that should permeate the institutions and the processes, or in other words, it should not be patient-centered care, but person-centered care. That is the main, what I can say.
Thank you very much. For me, personally, it was a great start because there were so many questions from the floor. We had experts here. Professor Ivkov, thank you very much, really, for informing us. That was fantastic. And now you deserved a break. So in case you would like to have some action, some stretching, then you just leave the room, past the elevator, and there, perhaps you've seen it, there's a little lobby. So there will be some stretching if you like. If you do not, then, well, have a coffee, and we'll carry on really at 11:30. So please be here at 11:30 so that we can start at 10:30, sorry, 10:30. And thank you very much.
and avvio,
So
and
you like
avvio,
the chairs,
and
is
avvio.
that what you're
1,
saying?
2, 3, 1, 2, 3. It's okay? Yep, thank you. Very sorry for the delay. I ask for your patience for 5 minutes because there is a very important interview of the president of EULAR to the national channel, and because one of the aim of the conference is to support the national league. So please make a little bit patient, and we start in about 5 minutes. Thank you for your patience, and we are a little bit late for starting our session. Welcome back. For those who don't know me, my name is Marios Kouloumas. I am the Vice President of EULAR, representing the patient organizations. And as you already saw in our opening, the topic of the conference is the patient-centered care. At least in this panel, the patient sits in the center. So welcome back, and I would like to introduce our speaker. It is a great pleasure to have our president, the EULAR president, with us, presenting about the patient-centered care and how this optimizes the outcomes. So Professor Burmester, the floor is yours.
For this talk, I also learned a lot, and as I told you, I wanted to become a psychiatrist when that helps a lot when you envision yourself to be a patient and how to interact, and because that's very important, because sometimes you're sort of blinded as a physician what the needs of the patients really are. So this is a very important subject. And can I get my talk? So let's see. Here it is. And so new avenues for successful outcomes are certainly needed. So you see here, this might be the situation in this cartoon. There is a patient lying down and with a lot of medication. So, of course, we all don't want to take that much medication. And when I make rounds in my hospital, sometimes the patients get 20 medications at top residence. Well, that is too much. Can't possibly give that much. And then they tell me, no, this is for the stomach, this is for the high blood pressure, this is for diabetes, this is for osteoporosis. And many of them are of course, important. But how to deal with these medications, these treatments, and how can we inform more patients? This is, of course, very important. So here, let me put forward the definition of shared decision-making that I took this out from a medical journal paper, and it says an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. So this, I think, is a very good definition, a little bit complicated. I will tell you a few details here. So there are 4 criteria for shared decision-making. At least 2 parties, patient and doctor, are involved in the process. They share information. The importance is share. Both parties undertake steps to achieve a consensus regarding treatment preferences. And finally, they agree on a form of treatment which is then initiated. So this is here the various key process. First of all, you have sort of a choice talk that conveys the awareness that a choice exists. So let's say if you are, someone has experienced, for instance, a sudden cardiac death, of course there's no choice. You have to really take action immediately and start resuscitation. That's not easy. But luckily, this is not our daily life. So you have, first of all, tell that there are choices, and it is either initiated by either a patient or a clinician, and this may even occur before the clinical encounter. So a good example is a wife, before she encounters and asks me about a clinical decision regarding her own health. My wife goes to the internet, connects the information, and then she approaches me. Sometimes I feel a little bit offended. She doesn't go to me directly, but that's the way it is. And then she says, yeah, in the internet I read about these various choices and you for me. So then there is the option talk, and the patients are informed about treatment options in more detail. And then, of course, very important, the decision talk. Patients are supported to explore what matters most to them, having become informed. And there are patients who say, doctor, I'm so afraid of so many side effects. Please don't give me so much medication. And even though we inform the patient about possible risks, we have to respect this. And sometimes patients say, well, I want to get rid of any sign of the disease. I don't care if it's very dangerous. I just want to get rid of the pain or of others. So these are different attitudes that you have to take into account. The decision support, that is very important. So it needs to be brief enough to be used by a clinician and patient together. It doesn't make sense to have, let's say, hour talks and finally don't come up with a good solution. It needs to be crisp, and I will come to that later on, and that will be also a factor or workshop. And it can be more extensive, designed to be used by the patients either before or after clinical encounters, so that the patient at home can carefully read the information, because we all know that sometimes patients in the doctor's office, they're a little bit excited, forget what they really want, they didn't write it down, and they see the doctor is constantly looking at the watch and waiting for the next patient. So therefore, sometimes or frequently, you need to sit at home and be informed about possible decisions. Then you talk about the initial preferences, awareness of the option. The goal is to arrive at informed preferences. And finally, personal preferences based on what matters most to patients, predicated on an understanding of the most relevant benefits and harms. So EULAR and other initiatives have really helped quite a lot in order to put forward a new classification criteria. That is very important, because we want to identify our patients as early as possible. Early identification and early treatment is key. There's no alternative to that. Treat to target. Together with a patient, we must set a target. And a target in, for instance, inflammatory rheumatic diseases is usually remission, which is, I mean, when I started rheumatology, remission was out of the question, was not possible. We didn't have the tools. Nowadays we do, especially if we catch the patients early. And so remission, which means the absence of any symptoms, ideally, of course, on treatment usually, is our primary goal. Tight control. We already talked about this this morning. So the patients need to be seen frequently, or as frequently as necessary and possible, in order to control the disease and adapt treatment. And of course, it is very important to define what remission truly means. So the Treat to Target initiative was very, very important. It is an international initiative that has been updated recently. And among these overarching principles, I will not go into all the details. You can actually download the material for free from the Annals of Rheumatic Diseases. It states as the first actual item, the treatment of rheumatoid arthritis must be based on a shared decision between patient and rheumatologist. So you see, this is already the first overarching principle. And if you then go into the 10 key recommendations, it says the rheumatologist should involve the patient in setting the treatment target and the strategy to reach this target. And I had the honor to be among the panel designing these recommendations, and there was quite a lot of debate. So first of all, the patient, it said the patient should be informed and the patient should know about it, but then we said no, the patient should be involved. So really take active part here, and that is very important. So this is the treatment algorithm that we have. Rheumatoid arthritis is just an example. So it can apply, and I'll come to that later, for many, many other rheumatic diseases. So you have active rheumatoid arthritis. The usual goal is remission, absence of any symptoms, ideally. Sometimes we cannot reach this. Why not? Because it's a long-standing disease, there's already pain going on, there are joint deformities. So then we say, okay, in these instances, low disease activity is an alternative goal. And of course, this needs to be sustained. It's not good if you have a remission for a couple of weeks and then you lose it. So it needs to be sustained. And how do you sustain it? By actively controlling the disease and adapting treatment if the actual treatment fails or is not sufficient. And you see here, shared decision with patients. Whenever you see little asterisks here, and this is very frequent, there is a shared decision point with the patient. So does that work? And we'll just show you one example. It's a Dutch study out of the BEST trial, and they evaluated, does this really work in daily clinical practice? And yes, they could show it in an interesting paper published in Arthritis Care and Research last year. And yes, the rheumatologist, and this was a Dutch study, so we already heard that maybe in some other countries, the mentality needs to be changed. They generally agreed in the Netherlands with this concept and followed a 10-year follow-up, a dust-tiered treat-to-target strategy. So even for 10 years, it worked. So it's possible. Sometimes, of course, and we need to have better tools, there was disagreement with the disease activity score, because sometimes the patient may not feel well because of other factors, while the joints are completely normal. So then the disease activity score might be altered. Nevertheless, you still don't change treatment. So we need to work on this as well. And these results indicate the feasibility, nevertheless, of continued protocol-driven treat-to-target therapy. And for daily practice, adherence to treat-to-target therapy might be improved by adopting the structure components of a clinical trial. And that is very important, because many doctors, and I used to think that myself when I started treatment, I'm a doctor, I have the feeling how the disease is, I don't really need to score something, I know what's best. And nowadays, I feel that you have a structured approach. Even if you're a very experienced doctor and you say, this disease activity score is too high, even though I might not want to change it, I must do it because it's for the best of the patient. So like you do in a clinical trial, where you're basically forced to follow the protocol. And I fully agree with this notion, and our Dutch colleagues even went so far, and we can discuss this later, they let the computer decide in the clinical trial what was best for this particular patient. So, next it is, there are further initiatives treating spondyloarthritis to target, and treating lupus to target, and very soon treating gout to target will also be out. And we in Germany have designed a new way, which is now called treat to participation. I will not go into the details of it, but it is so that the aim is that the patient is informed and can participate, not just treat to target, but treat to participation. So how is this achieved? And EULAR, as you all know, is working hard on management recommendations. And you also know probably that in all these initiatives, there need to be at least 2 patients to be present. One is, for instance, Marius, I see him very frequently, and Martin de Witt, for instance, and other patients are present, and they help us a lot. Sometimes when they say something, we say, oh, really? We have to think about it as physicians. But of course, and that's easy. In a university setting, and I'm a university professor, there are 2 parties that are always right: the students and the patients. They're always right. So it's that easy. So even though you may have a different opinion, but you, of course, have to respect what they think and integrate this into the recommendations. And that's what we do. For instance, here we have the EULAR rheumatoid arthritis treatment recommendations, which, as we sit here, are currently updated. Marius knows the process. We just came back from Vienna for 2 days, worked on these new recommendations, but based on these former ones, and this will not change. You see again, treatment of RA patients should aim at the best care, and even stronger, must be based on a shared decision between the patient and the rheumatologist. This is the EULAR situation. If you look into the most recent paper published by the American College of Rheumatologists, I carefully read the paper, and I put in the search machine shared decision. Nothing came up. Actually, it's not present in the American paper. But what I found in this paper is, and that comes a little bit closer, is this sentence: these recommendations, which focus on common clinical scenarios, should be used as a guide for clinicians treating RA patients with a clear understanding that the best treatment decision can only be made by the clinician and, interestingly, in discussions with patients. You see, different approach compared to the EULAR situation where we say participation and shared decision. They said discussion, whatever that means, taking into account their risk-benefit assessment, including consideration of comorbidities and concomitant medication, patient preferences, importantly, and practical economic considerations. So they're not, in my eyes, even though I was trained in the United States and I highly respect my American colleagues, but I think they haven't advanced that far as we have at EULAR, where we take this probably even more serious than our American colleagues. Now let's have a look, because there are people who say, well, shared decision, it's very complicated, should we really need this? Is there any evidence that it leads to a better outcome? And that is, of course, a matter also for the health insurance companies and the payers, because ultimately shared decision needs resources that are taken out of the entire budget of the healthcare system, and the payers may ask, well, does it really make a difference? Does it change outcome? And for those of you who are interested in that particular research, this is a paper which you can freely download from the internet, from the German Doctors Association's journal magazine, and that investigated outcome-related effects of shared decision-making. I cannot, as a systematic review, quite interesting, and there are, and you don't have to go into the details of the table, there are studies in which the intervention improved patient-relevant outcomes compared with the control group. So 50% basically of the patients were informed, took part in the decision, so it was a shared decision process, and 50% of the patients didn't have that opportunity. So now you compare, was the outcome in group A, shared decision, better compared to group B, where there was no shared decision. And here you see examples like diabetes, ulceration, breast cancer, interesting, even schizophrenia, which is quite interesting, bronchial asthma, arterial hypertension. Yes, it made a difference there, but there were also studies in where it didn't make a difference, like prostate cancer, patients' antithrombotic treatment, depression, and others. So we still need a lot more evidence and a lot more studies in various diseases in order to come forward with the best possible ways to implement shared decision in improving outcome. So many drugs we have now, and of course, we can only make a good decision if we have decision aids. And you see here already the multitude of drugs that we are confronted with in rheumatology. And if I say rheumatology, we are not just rheumatologists, we are internal medicine doctors. Our patients have diabetes, our patients may have hypertension, they may have other diseases that we need to take care of, hyperlipidemia, and so on, and we need to take care of this as well. So in some ways, a rheumatologist is also a family doctor. And that is the beauty of our discipline. We are not just interested in the heart and no other organ. We are interested as a rheumatologist in the entire person. So no shared decision making without decision aids. So it can be a communication between doctor and patient, between health professionals and patient, and that is what I believe is extremely important, the communication between the health professional and the patient. Because you all know, let's say I have about 15 minutes for a regular visit for a patient with a rheumatic disease, not more. 15 minutes because my schedule is so full. So can you convey all the necessary information there? No, you can't. So therefore, you need additional tools, and I strongly believe in the communication between health professionals such as a nurse and a patient. It's sometimes amazing if you talk to the nurse later, you say, yeah, the patient informed me about this and that, the patient had this and that question that the patient never addressed to the doctor because the patient was too excited, was afraid that the doctor was in a hurry, other reasons, so therefore this is very important. Communication among patients in groups is very important, and that's what we're sitting here because we have the patient organizations who inform themselves about the best possible treatment. Communication in the family may be very important. Sometimes it's unfortunate because I treat a patient with a certain drug and the patient comes back and says, yeah, I like that drug, I would like to take it, but then my son said this is poison, don't take it. So I'm not going to take it. So because the family is influential, and you need very frequently also inform the family and ask the wife or even the children of the patients to come along and inform them as well. And then you have information materials such as leaflets, books, TV broadcasts, internet-based material. Why is that necessary? Because the patient and also the physicians are overwhelmed by the package insert. You see, I took a photograph of a package insert for a biologic. This is only one page. You can turn it around and you have another one. I put a ruler of 30 centimeters there so that you have about 70 centimeters of information in fine print. Can you really deal with this? It says about 40 general side effects, about 40 side effects from clinical trial. So all in all, 80 potential side effects, of which only 1 or 2 may be really important. So you really have to condense this information, which we are doing in the German Society of Rheumatology. Then, of course, and you see here, I translate this cartoon. I'm proposing a trade-off here, says the doctor. First, you report in 5 minutes what your magazine tells you, and then I tell you what I recommend. And this is also a frequently encountered situation. Patient comes into my office, shows me a magazine article, maybe completely reasonable about a new treatment, or completely crazy because it's a very strange treatment with sea urchins or whatever, and it's not so easy to inform the patient that this may not be the best possible treatment in this case. But it takes time to talk about this. Or this cartoon here, to make your decision easier for or against this treatment, the doctor says, I will now inform you about the results of the most important multi-center randomized double-blind trials. And you see the multitude of information that is present. Of course, we have hundreds of papers informing us about all these biological treatments. We have 9 biologics. Each biologic has at least 10 papers or more. And to condense this information for the patient is, of course, very important. So the EULAR School of Rheumatology, which we will launch very soon in June at our annual meeting, might be a new avenue to generate, for instance, decision aids. So let me give you a little bit of a background. So there is a steering group consisting of myself, Hans Belzma, and Anna Maria Janocco and Gabriela Kluge from the staff. And this is based on our goals of EULAR. We want to really be the preeminent provider and facilitator of high-quality education offerings for physicians, health professionals in rheumatology, and people with rheumatic and musculoskeletal diseases. So we formed the school, and we have several classrooms, like in a real school. Medical students, teachers, trainees, rheumatologists, you see colleagues involved who have expressed their interest in teaching and generating educational material. And of course, there's also the group of PARE you see here, and Dieter sitting there. He's a teacher by training. He's a real teacher. I think in geography, Dieter, is that correct? Yes. And some other things. And of course, I think he used to teach geography in English. Is that correct? Because his English is, at least in my eyes, nearly immaculate. And so there are Dieter and other colleagues involved. I think they're all here. So at this meeting, and so we can generate the best possible material here. For instance, enhance the patient partner program, which is very, very important to the development of rheumatology in general. And we would like to create a website, install a EULAR portal, and of course, also for the health professionals, it will be important that we have a EULAR certification and point system, so that if you encounter a physician who has maybe 50 points, at least you know that this physician has been well trained in rheumatology, because otherwise the physician wouldn't have that many points. So the key messages, and we will allude to that, to many of these aspects in the workshop as well, are if treatment adherence is enhanced, clinical outcomes can be improved. Because the worst drugs are those that the patients don't take because they are ill-informed and are afraid of a potentially very good drug that is necessary to keep the disease under control. So adherence is key, and a key adherence is shared decision. So it can be optimized by patient participation. Shared decision is considered now a gold standard in patient participation. It can have a positive effect on patient-relevant disease-related outcome, even though more trials and better trials are necessary in order to implement this. And the studies, as I mentioned, available so far indicate the need for minimum standards regarding implementation and investigation of shared decision-making, which is very important in also to convince the payers and the health insurance company that this is an instrumental and a key part of our daily life in the best possible care. So thank you very much for your attention.
Thank you so much, Professor. Please join us to the panel. Really excellent presentation. I think that you have set up the scene and you gave us a good base for the later discussion. So thank you so much for that. So we're going to have our panel discussion now, and I would like to introduce to you our panel members, and allow me to start from the ladies on my right. So we have with us Boriana Podeva from Bulgaria. She is the Vice President of the PARE Organization. And we have our professor, Sofia from Bulgaria, representing the Rheumatology Society. Thank you for being here with us. And we have Christina Obama from Sweden. She's the Vice President representing the health professionals. And we have on my left, Dieter the Chair of the Standing Committee of PARE, and our EULAR President, Professor Bulmester. So welcome everybody, and thank you so much. And I would like again to start from the ladies first and from the left. Just the first statement, and please, very, very short. What is the most important element for you, from your perspective, of the patients living there?
Thank you. Does it work? Thank you for your question, Marius. As a patient myself and as a patient representative, I think that the most important is the care to be individual, caring about needs and the preferences and the values of the patient, and also to be coordinated. For example, you know that rheumatic diseases are connected with a lot of comorbidities. If we need to visit another specialist, we would like our rheumatologist to connect with the specialist, to talk, to discuss. And that, in that way, I think that we as patients will feel that we are cared enough, and we have personalized care from our rheumatologist.
Thank you very much. Please, Professor.
For me, it's very important this update version of the treatment recommendation for the rheumatology practice, because the education of patient is a very aspect greatly improve the contact with the doctor. And I would like to repeat that in our country it's possible to make the team with patient organization, rheumatology experts, and presenting from regional health inspection to this team rheumatology group who make the center care of patient of rheumatic disease in our country.
Thank you. So, from the professional perspective, what is the most important?
Yeah, I would say that, as we heard, treat to target does not always lead to remission. And even if remission is reached, not all the symptoms are always gone from the patients. And thus, there are other health professionals that can be involved, of course. And I would also say that shared decision-making about drugs is not the only thing that person-centered care means, but it also means education and exchanged information. And I think that health professionals have a very important role here. And as we heard Professor Burmeister also say that if you listen to a nurse or to a physiotherapist who has more time with the patient, then the care will be more person-centered. So one thing that wasn't on the slide, but that you actually said, was that not only communication between doctors and patients, health professionals and patients, but also between health professionals and doctors.
Thank you. We have another microphone. So, teacher, as a chair of all the organization representing 120 million patients in Europe, so what is your highlight?
I would just like to concentrate on the shared decision making. I think it's about 2 years ago, I went to a conference of DGH in Germany, and there was a panel discussion also then, and the question was, are you going to include patients in that decision? And they could give a vote, it's technically possible, and there were only a little more than 50% who accepted that. They were mainly GPs. I think that's the reality if you think what is happening yourself. Why does that not happen? I think we must be fair. There are lots of obstacles why this does not happen. One obstacle to my mind is the reimbursement system, at least in our country we've got. So there's some other obstacles as well. So what can we do? To my mind, there are two things. We could, as a patient organization, we have one target group, that's our patients. Empowering our patients that they are really informed. We saw that on the slides, what patient organizations can do. And that they, well, when they go to their doctor, that they really can ask the questions, that they really can respond, and that they do not sit the way those two patients were sitting. If you remember that cartoon, one was really down and the doctor was up. So that there's really this kind of equal level. And the other thing is, to my mind, that we really support patient organizations, that they have got the material, that they have courses for their patients, so that they really are supported. And this aim is really achieved that we can say not 50%, but let's say 80 or 90% really participate from that shared decision making.
Thank you, Dieter. So, Professor Burmeister, I would like to ask you and to have the hat of the president of EULAR, representing more than 100 organizations in Europe, and as you said, unique because you're representing care professionals, patients, and clinicians. So, from your perspective, what is the most important that maybe EULAR can do in order to promote the patient-centered care?
Yeah, first of all, EULAR will and must generate the spirit that this is really essential. As Dieter already pointed out, many physicians, not so many in our country, but maybe if you do a secret vote, it may be different. It was a secret vote, and people tell what they really mean. Because if you ask them, everyone will say, yes, of course, it's very important. But you need to generate the spirit, and as we just learned, that the spirit may not be always present in countries like Bulgaria, and that, of course, EULAR can help to generate the spirit in all the countries of Europe. But not only Europe, we will help also the Asian and the Latin American and other colleagues as well. I think that is, EULAR can be at the forefront, so that everyone accepts that shared decision is really essential, which would already be a major goal. And secondly, EULAR can provide the means how to generate shared decision, and I think There's no shared decision without decision aids. That is very important. And so if you look into, because there were recent papers in the New England Journal of Medicine and so on, there are procedures, cardiovascular or cardiology procedures, where you can either have a device in your heart or you can do medical treatment. So this is not an easy decision, not even for the physician, to say, well, do I need surgery or do I just take some drugs? And what is the best for me? And so there, the colleagues in cardiology have generated very nice decision aids informing you about the procedures, about the alternatives, the pros and cons. And that is what EULAR can do with the EULAR School of Rheumatology, because, I mean, we take care of 200 diseases, and we take care of, we have so many, luckily, treatment options, and rightly, they do not only include drugs or surgery, they also include physical therapy, which is very important, occupational therapy, spa treatment, and others, and that is also an essential part of the information. And also we have, I don't know, probably more than 20 languages to take care of. That is also very important. Of course, this is a challenge, this is sort of a barrier, but also it's an opportunity for EULAR together with the local organizations to have translations. And because many people say, oh, this is very difficult to translate it, but this currently, as we sit here, everything we are saying is currently translated into Bulgarian by a simultaneous translation. So it is, of course, it is an effort, but it's possible. And we need to open up our minds to not say this is a problem, will never work, because we must attend and direct our attention towards solutions. And I'm not a fan of complaining, because rheumatologists like to complain a lot, and rightly so, but that doesn't help us. We need solutions. And solutions can be provided in many ways by EULAR, since we are in the unique situation, I stress this again, of having the three pillars of patients, health professionals, and physicians. And this is a prerequisite nowadays to have the tools for shared decision making.
Thank you so much. So just to remind our friends who are joining us through the live stream, through the website of EULAR, that they can send their comments and questions just using the Twitter and the hashtag PARE 2016. And now, of course, the floor is open for you for any comments, questions. Please just take the microphone, state your name, your country, and your question. And I like to ask you to be very short because we don't have much time for that. Yes, I have a question from Florian from the Twitter. Yes, Florian.
Thank you, Marius. We have received two questions via Twitter. One is, what happens if there are more specialized clinics involved or specialty doctors? For example, if you're going to do two different clinics, how can you enable shared decision making if in one clinic you're regarded as an arthritis patient and in another one with another disease? And the second question was, should the concerns of increasing cost of medicines be also part of the discussion on shared decision making?
Okay, who wants to answer that?
I maybe can allude to the first question, because this is a frequently encountered situation. I would definitely not say problem, because you need, as a rheumatologist, you need to create a group of friends that you have in pulmonology, in orthopedic surgery, in neurology and dermatology. That is essential. And they shouldn't be just specialists, but they should be friends. And that is very important, because there is no competition. And usually the rheumatologist should be the pilot. And the pilot will, of course, need information from flight control, from the weather system, and so on. And the pilot will collect this information and then will have the best possible path leading to the final destination. And that's how we do it. So whenever a patient has a dermatology problem, I know, oh, this person is the best one, and I will ask the person, please inform us about the patient, and then I'll discuss it with the patient and together with the specialist dermatologist to find the best possible way.
Thank you.
May I add one thing concerning that? I think this really happens, to my experience, if you've got a clinical setting. And that's the problem. But if you haven't got that, that is not available, then there is a difficulty. The difficulty is that information is exchanged, that really cooperation happens, and so it is fantastic if you've got that, a clinic, and you have got these friends working together.
May I just comment? But of course, if you are, let's say, a doctor practicing alone or together with one or two colleagues in a practice, it's more complicated. But also these colleagues usually have a group of friends who are also dermatologists, close by, neurologists. But it's more complicated because it takes more time until you have seen the other neurologists and until there is feedback. And that's why we see in very complicated and critical situation, we see the patients in a clinical setting in order to speed up things.
Thanks. So, any questions, comments? Yes? Here. A microphone, please.
This is Raj Mahapatra from the National Ankylosing Spondylitis Society in the UK. In the healthcare industry, we have the concept of the payer, and the payer is either the insurance company or sometimes it's a governmental agency. Often, I think that one of the reasons why you have a challenge getting patients involved in healthcare discussions is because the patient's taken out of the picture because the payer is seen as insurance companies or government agencies. Whereas actually the reality is the payer is the taxpayer who pays the government to pay the pharmaceutical companies, or it's the insurance premium payer who's paying the insurance company to pay the healthcare bills. Do you think, at the moment we have a move away from national healthcare systems into insurance-led healthcare, do you think that this will help or hinder patient-centered care?
Who wants to answer that?
Yeah, I can let's say address part of it because it's a very complicated issue because you have so many different healthcare systems in Europe, and so therefore the Bulgarian healthcare system we learned today is certainly quite different from the German one, from the French one, and as you pointed out, the British one, which is basically taxpayer paid, while in Germany we have 100 health insurance companies, and each one has a different attitude for payment. Some health insurance companies have a great program in educating patients, they support it, and some are not interested at all. I think what we need to do, and that takes, as I mentioned, a lot of work, is to convince the payers, the health insurance companies, for instance, that patient-centered treatment and shared decision is leading to a better outcome and stronger adherence, and then they will eventually save money. Because let's say for instance, this one example, you can now cure hepatitis C, but the costs in Germany are 50,000 euros for the cure of hepatitis C. So the health insurance companies in Germany have said, yes, we agree to this enormous amount of money. However, we're quite afraid that the patients don't take the drug that we pay for. So for them, adherence is extremely important. Imagine you pay such a lot of money, the disease is not cured simply because the patients don't take the drugs. So there you can easily convince the health insurance companies that shared decision in an hepatitis C setting where the patient must consent to the treatment and take the treatment regularly, which leads to a cure, however it is very expensive, is a good thing. And these are the examples that you need to put forward to the health insurance companies to really take it to heart and eventually reimburse it as well by schooling and by giving enough money to a discussion with the patient, which currently is not the case.
Thank you. Christina?
Yeah, I would also like to comment that now that the drugs are much more expensive, there is also a reduction in rehabilitation, as we heard, even for Bulgaria previously today. So from maybe 4 weeks to 1 week, or in special cases 2 weeks. This means that healthcare professionals in rehabilitation need to work in new modes. It couldn't be any longer them making the patients healthy again, but they have to give the patients tools to self-manage much more. And that really calls for person-centered care, because you can't make someone self-manage without taking into account their whole life situation. So I would say maybe if we work more efficiently and cost-effective, it requires a more person-centered care.
Thank you. Yes, please.
Thank you. I'm Ella Vine. I'm a board member of ENFA, European Network of Fibromyalgia Associations, and I'm chief executive of the UK's Fibromyalgia Action UK. And I just wanted to refer what Raj just said about the payers, whether they're like local trust or insurers or governmental organizations, whatever they are. I think that the payers should include some patients' representatives on the payer board. In whatever country, in whatever shape and form those payers are, I think it would be very good to campaign perhaps for that. So patient representatives must be included in those payers. And another thing, with this notion that patients don't take drugs, so therefore there is that excuse for politicians and the payers and others not to offer drugs. In the UK recently, there's an example, the Health Secretary Jeremy Hunt used this, and that's kind of like a political, basically, talk, to kind of blame the patients that are not taking the drugs. But I think that's not fair, because the patients want to do everything to feel better and to get better, and to use this sort of notion to kind of switch the blame, where the general population may not understand what invisible disability is. It's really dangerous, and it's something, used sometimes by politicians and the others for a purpose, and I think we have to be careful with that. Thank you.
Thank you. So patient participation is very important, also for the design and implementing policies in here. Yes, Oriana.
I just want to comment that point that you proposed patients to be included in the health insurance. I can say that in Bulgaria we have, in fact, a patient representative in the National Health Insurance Fund, but I must point that we should be careful, because if there is just one person, he can become, how to say, not independent. He will be not independent. Maybe we should be careful when we want to be included in this health insurance funds, for example, or we should have a lot of representatives who can change in order to stay independent. So we should be careful.
Okay. You want to comment on that?
Just one remark concerning adherence, I think, what you said. Adherence, there are lots of surveys, I think they show that sometimes there's only adherence of 50% or 60%. We must be careful. Adherence is not only based, let's say, on this patient-doctor relationship. If there's no adherence, there are many factors why it is like that. And I personally feel that the patient himself must be also seen as an individual, and the patient is responsible. Certainly we must, as we said before, empower patients, but nevertheless the patient is responsible, and if he sees that, well, I will not take that pill, please go to the doctor and say, well, it does not work, I don't want to take it, why is it like that? So What I do not like personally is that all kinds of responsibilities are then given to others, and the others are in charge, and not I am personally in charge, in my opinion.
Okay, thank you. Of course, sorry, but we have extended our time, and I know that we follow and we have more time for discussion in the workshops. Actually, the workshops is a place that for all of you can be very active contribution, and the place that you can discuss all these things. I just want, we have already extended our time, but I think that we like to have a final word, a final remark statement from all of you before we close our panel discussion. And we start again from our lady on the right.
Hard part to start. What can I say? I believe that patient-centered care can be achieved by partnership between doctors, patients, patient organizations, health professionals, and institutions. That's what I can say.
Thank you. Thank you, Mariana. Professor Younger.
Yes,
A very final remark.
the dissemination of this new recommendation and new approach as well healthcare professional, doctors and support patients and care to manage their diseases.
Thank you. And of course, we look forward to collaborating together, maybe translating recommendations in Bulgarian for the Bulgarian patients. Yeah, thank you.
Yeah, there's a lot of small talk going on between health professionals and patients while preparing for infusion therapy or in a hand exercise group. And all of that small talk helps patient-centered care or person-centered care. So when you share information there, you form a basis for person-centered care. So don't forget about that information that health professionals have.
Thank you, Christina. Dieter, you have a final remark?
I want to follow up. Well, patient-centered care means for me there are different people, different groups involved. The GPs, the rheumatologists, the health professionals, physiotherapists, and so on. And what I would like personally as a patient, that, let's say, there's more exchange of thoughts, of ideas, that there's more cooperation, because this helps the patient, it helps the outcome, and it really saves money in the end. So that's why I'd like to have that this is really improved.
So it is a win-win situation. Thank you.
Yep. I can only agree to that and echo these remarks. I think shared decision is key to best possible treatment. In the end, it will save money, as Dieter already pointed out. We need just to make that clear to the payers. Nevertheless, we need modern tools for the best possible education. That means decision aids, and hopefully EULAR will be possible at EULAR to provide the best possible tools for all the patients that we take care of.
So thank you so much, everybody, and I think we deserve a warm applause for our panel members for this discussion. So very quick, I would like to introduce to you the next workshops. So in your registration form, you remember that you have indicated your first choice and second choice of the workshop that you would like to interested to attend. We make all the efforts in order to accommodate this, but of course you have understand that we have also many people registered for a workshop, and we like to give an equal numbers for all the 4 workshops. So we did the best in order to accommodate your registration preference for the workshop. Please check outside of the room. There is a list of each one of the workshops, the participant lists. Please check that in which one you have registered. And please be aware that we don't accept any swap of the workshops. So you have to go to the workshop that you have indicated in the participation list because we want the number of the people attending these workshops. So all the breakout rooms will be in this floor. So we're going to have a workshop here, and the other 3 workshops will be in the breakout rooms on the other side of the building. So it's nice that we have all the workshops rooms in this floor. So this is the workshops, and please check outside in which one you have registered. So after the workshops, please go to the lunch, which will be served in the restaurant of the hotel, in the Seasons restaurant. Please be sure that you return to this room for the workshop feedback at 14:15, so 15 past 2, in order to start promptly at 2 o'clock, 20 minutes. So now, please, everybody, I know that we have short time. Please be sure that 11:50 you will be in the room ready to start the workshop. So, thank you so much.
Okay. Das ist eine schöne Nachricht. Ja. Ja. Ich würde sagen, rotiert sich auf jeden Fall. Auf jeden Fall. Ja, ja, na klar. Genau. Nö, genau. Na klar, na klar. Zumal wenn ja, nee, das ist sicher. Zumal wenn wir diese Konstruktion machen. Das ist ja noch leichter. Nee, da bin ich absolut sicher. Ich kenn das. Ja, ja. Ich kenne das ja auch gut. Ich mache das ja auch immer ganz gerne. Genau. Okay, nee, das ist okay. Ja, ja, genau. Ja, ist klar. Genau. Gut, ja, dann freue ich mich und dann auf die Zusammenarbeit. Alles klar. Okay, vielen Dank. Alles Gute. Ciao.
ovo, ne, hoćeš ovo uštakati u tali 1. Moram ištekati onaj predsjed.
Tako.
Jesi treba ovaj mikrofon pomoći? Yes, yeah. You can also sit here.
Hello. Hello. Just watch you. Microphone.
Okay, welcome to this first breakout. I hope you enjoyed the first morning program. Now actually it's time to work. You have been listening now, but we hope now to become a little bit more active, and we will also have some assignments in the groups. My name is Martin Grit. I'm from the Netherlands, and I'm part of the working group that prepared the program for this conference. And it's my pleasure also to introduce Yvonne van Eyck. She is a practiced nurse practitioner, also from the Netherlands, and she has been very active in a EULAR working group looking at comorbidities and how you could deal with comorbidities and screen and report about this. And because we know that comorbidities is something that is important for many patients in many different diseases, we thought it's important to pay attention to this and also to this project. We lost already a little bit of time setting up the room, but it's great that you are here. And I think I would like to hand over to Yvonne. She will introduce the topic and this screening tool, and after that we hope to discuss with you how this new tool could also be of help in your countries.
Okay. Without microphone, it's okay? No. You can use this microphone.
Okay. Thank you, Maarten, for the introduction. And thank you all for being here, because I think it is an important topic. What I want to do in this short presentation is tell you something about the recently developed and published EULAR points to consider for reporting, screening, and preventing morbidities. We heard this morning that patient-centered care, person-centered care model, it is required that you are involved in your care, and one of the key issues to become involved is that you are involved. But our workshop is about raising awareness, about informing you, without raising anxiety, because talking about comorbidities may raise questions and anxiety, and that's not what we want. For us, it is very important that we get your information, that we get your suggestions and feedback from the workshop. So therefore, it's really important that you understand what we are talking about. So please, I try to explain well, and if you do not understand, just ask. Well, what are we talking about? Comorbidities. Many people develop some kind of disease in the course of their life, and also having a rheumatic disease doesn't prevent you from getting another disease. In the project that I'm going to tell you about, we focus on comorbidities in chronic inflammatory rheumatic diseases. And that is what the abbreviation is about. And then think about diseases like rheumatoid arthritis, ankylosing spondylitis, gout, all diseases that are characterized by inflammation in joints. When we talk about comorbidities, we talk about a disease or a disorder concurrent with your rheumatic disease in this case. As we are in the field of rheumatology, we think that the rheumatic disease is the primary disease and everything around that is another concurrent disease. Well, there are diseases that simply occur, that are independent of your rheumatic disease. Everybody can get them, and an example, for instance, is Parkinson's disease. It's only an example. Many things can happen in a man's life. But there are also diseases or disorders that can be related to your rheumatic disease. And some of them can be related to the disease itself. There is increasing knowledge that, for instance, people with rheumatoid arthritis have a higher risk of getting a cardiovascular disease. And it is a risk. It's not occurring, but it's a risk. But there can also be diseases that can be related to the treatment. You can think of pain medication that can cause stomach pain and, for instance, stomach ulcers, or steroids that can cause or contribute to osteoporosis. So all those things we call comorbidities. And the reason why that project was established is that, as I already told, that for some diseases the risk for people with rheumatic disease is higher, the cardiovascular, for instance. But in some countries, the health system is like this, that when you have a rheumatic disease, that you are not included in, for instance, public health screening for other diseases. And that's not the same in every country, but in some countries it's really a problem, so that by having a rheumatic disease you are excluded from care for other diseases. Then you can imagine that having more than one disease can be complicated in the treatment. And for instance, when you look at rheumatology, when you have an active disease, the rheumatologist may consider to treat you with steroids, with prednisone. When you have diabetes, for instance, you have high levels of blood sugar. And steroids can also increase your level of blood sugar. So that's a difficulty in the treatment. And then the third reason is that some comorbidities may affect outcomes of the treatment. For instance, there has been some research that people with obesitas, with large overweight, may respond less better on treatment than people who do not have obesitas. So those were the reasons to consider to have extra attention for comorbidities in rheumatology. And the objectives of this project were focused on daily practice and to look at screening and hopefully by that preventing comorbidities, and also to make sure that data that are collected for the screening are reported somewhere in a form that is recognizable so that everybody knows that you are screened well. And in the project, it was decided to go for a selected group of comorbidities. And you can consider all diseases that are present that may occur as a comorbidity when you have a rheumatic disease, but that makes it really complicated to screen. And finally, in the working group, it was decided to focus on a selected group of comorbidities based on their frequency in rheumatology, but also based on potential severity. And we choose 6 comorbidities to focus on, which is cardiovascular disease, malignancies, which is cancer, infections, peptic ulcer, the stomach ulcer, osteoporosis, and depression. Are there any questions until now? Is it clear what I'm telling? That's great. Well, it is a EULAR project, so we followed a EULAR procedure, which also always includes a literature review. And for this project, guidelines, international guidelines with regard to screening or prevention of comorbidities in rheumatic diseases were searched for. And if these were not available, they looked to international guidelines in a general population, in all people, or if these were not available, they looked at national guidelines. And we finally only used topics that were found in the literature somewhere. So things we couldn't find were not used for our final results. Then there are always consensus meetings, and these meetings with a group of people, in this case there were many patients, nurses, but also physicians. We discussed formulating this project, what are the important issues, what are the overarching principles, so-called. We finally formulated points to consider. In EULAR, they have a structure to develop recommendations, points to consider, and they call it recommendations if there is sufficient evidence. If the evidence is low, is limited, you cannot call it recommendations, but they call it points to consider, which means that the evidence is low, but nevertheless is considered important. And we also discussed a reporting form, and that is the thing we are going to talk about later on also in the subgroups. Well, what did we formulate as an overarching principle? We said somewhere the rheumatology team has a responsibility in detecting and in collecting data. And it was mentioned that in the rheumatology team, it was the rheumatologists, but also health professionals, such as nurses, And patients were mentioned as part of the team. And when you think about the discussion we had in the previous session, which was about patient involvement, responsibilities, here is a statement that really tries to include that. But it's difficult, and we're going to talk about it. Furthermore, we said we are going to recommend or consider detection and collection, but not management. Because in many countries there are specific management guidelines in other disciplines. For instance, what the general practitioner should do, family practice. So we only decided to go for detection and collection, and the idea was that the management can be decided in a country or maybe even in a region. And then another principle was that screening for comorbidities should be part of a standardized program. And the idea is that it is pretty useless to once measure a blood pressure, for instance. If you want to do something with it, you have to do it regularly, and the 5 years are because some of the screening items that are in the checklist we are going to discuss, when you know it, it's okay, and you have to check up if it should be updated. And other things you should really screen regularly. For instance, I mentioned blood pressure. You should measure blood pressure regularly when you want to know if a blood pressure is well controlled. Then the points to consider. In EULAR, you always produce a table with bullet points. And we did. We produced 15 bullet points. And these bullet points are about the 6 comorbidities I mentioned. And they are about that there should be some report of a history of a disease or currency of a disease. That, if appropriate, there should be screening on risk factors, because finally you want to prevent comorbidity, so you should screen risk factors. And if appropriate, you can say something if people are treated. And the discussion was, for instance, in the group with regard to the cardiovascular disease, that high blood pressure is a risk for developing cardiovascular disease. When someone is treated with medication, he might have a normal blood pressure, but nevertheless, the treatment itself says that there is a risk and that it should be monitored once again. Then we produced the reporting form. And you all have an example in English on your table, the full reporting form. So we're going to look at it more in depth right away in the subgroup discussions. And it is really an extensive form. And finally, in the end, when you check them, there are 93 questions. And you can imagine that it is complicated to implement this. So that's a huge discussion. And that is something that we are struggling with now, that how can you use this form, which all contains items that we consider important, how can you use that in daily practice? And more specific, because that was one of the things that was mentioned, as I said before, that as patients are part of the rheumatology team, how can you involve patients in this screening, in this extensive checklist, with a lot of difficult words, which might be frightening, which might cause anxiety? That's not what you want. But you want to do something with it. I want to show you the example of the cardiovascular risk, which is in the full checklist. And you can see, maybe not very well, but you can see that for cardiovascular comorbidity, there are three domains. There is a domain of report in having a disease or having had a disease. For instance, having a stroke, have had a stroke somewhere in the past, or current heart failure. There is a list of risk factors which are associated with cardiovascular disease to be checked. And you see the wording, it's really complicated, but it is about smoking, it is about having diabetes, having a bad renal function. And there is a list of treatments to be recorded. Really, really extensive, yeah. Yeah. Pardon? No, exactly. So that is the issue we were talking about. When you go to your rheumatologist, how can you ever implement this? And you can consider, because it is really meant to improve daily practice, you can consider that there are registration systems where you can simply put them in, and you don't have to do that all in one consultation. But the issue is that when you want to involve patients in it, you have to present a kind of tool which is useful for patients. How do you ever know if you are screened well, or if you are treated well, or if something needs attention? And do you want to know that? Do you want to be involved in this complicated matter? That is what the project was about. So what we are struggling now with is how to proceed, what is the next step, and that is why we really need your input. So what we did is that we formulated a few questions, and we will ask every table to address at least one of the questions, so that we at least have answers or suggestions for each of the questions. If you have time, you can discuss further on the other questions. We have moderators per table. I will moderate this table. I will join you in the discussion. Nicolas, we are very happy that you wanted to support us, and you will moderate your table, and Maarten will moderate that table. Did I mention everything we need? Was I clear, Maarten? Because we talked about it's complicated material, and I really want to explain it well. Are there any questions until now? It's all clear? I think I explained it very well then. Thank you.
Okay, thank you very much, Yvonne. It might be very clear, or it might be very complex and still difficult. I think if this is the first time that you are confronted with this, it might be quite overwhelming. At least that was it for me when I was confronted with this the first time. Before we continue, we just want to tell you a little bit more about another project of PARE, which had exactly as the objective, if you have information, medical information that's relevant for patients, how could patient organizations also benefit from this information, and what needs to be done to get medical information also accessible and understandable for patients. And in this project, it's a PARE project that we have been carrying out over the last years. We have developed a kind of guide, that helps patient organizations, but also EULAR, to think about different ways how you can make information accessible. And we present it here because we think that the guide could also be helpful when we think about this screening tool and how we could use that in clinical practice. It's very brief, but it might be useful for you to know that we have this guide when you want to do something about this instrument or about recommendations that you would like to share with your members and with patients in your country. Just very briefly, what do you find in this guide? We formulated some overarching principles, and we also made some recommendations. The guide was meant to be very practical, so that means that you will find a lot of tables, checklists, things to do, things not to do, pitfalls, but also advice about the time frame, where do you get money to do it, and whom should you collaborate with if you do this, because that is one of the overarching principles also. If you think about disseminating information to patients, try to collaborate also with health professionals. There are a couple of these recommendations, and I have selected here only 4 that I think would be relevant also for today. That, as you see now, we have a large document with 96 items. So the question is, how can we make this also accessible and understandable for patients? And as Yvonne said, what is needed to avoid that patients are frightened or anxious when they see this list? So that means that we have to think about a way of introducing these recommendations, maybe in a lay version, maybe with some additional information. Of course, when we develop that information, it will be in English. So there's also a need to translate this into the languages of your countries. So that's already one of the challenges. How are you going to translate what we have now produced in English to a national, on a national level? And then, and this is the 3rd bullet point, if you think about disseminating this instrument, think about not only a paper version that you give in a leaflet to patients, but think a little bit more broadly in other ways that you could introduce this instrument. Like nowadays, we have social media, you have your patient magazines. There is a role also for the health professionals. They could give presentations, just introducing why are comorbidities important and why do you sometimes have to think about them. And then the last bullet point says is that if you want to do something about comorbidities in your country, think about the partners that could help you in setting up a project or a campaign, or simply how you could introduce this instrument in practice, in the hospitals, in rheumatology care, and maybe also in your conversations if you have contacts with general practitioners. So these are a few recommendations, what you could think of. And this is the final slide, which says that if you are producing materials, these are things that are important. Try to be as short as possible. Avoid unnecessary information. Use familiar wording, so just words that we use in daily life. So avoid medical jargon. Use short words, which is already said. Try to be clear and consistent. Use active voice, which means, for instance, that you say, you should do this or you should do that, but not make it a passive sentence. Short sentences, short paragraphs, and there are some indications what that means. And it all comes really down that if you produce this, test your information also with some patients and ask them, is this understandable or not? Because it might be that you are a little bit more knowledgeable on these topics, but it might be that patients who are confronted with this instrument are less knowledgeable about these items. So you should really try to use simple language. So this is a little bit of background material that could be helpful. Any questions? Okay. Then I think it's time to break up. You want to introduce the breakout groups? Yeah? Oh, maybe I can also do it then. Okay, what we want to do is we have formulated, and it is also in your working book, there are 3 questions that we would like to discuss. And because we want to have answers on all three questions, and time is limited, we have decided that your group is starting with question, Nicola. Do you remember? Yeah, okay. You are doing the second. You are starting with the first question that is mentioned in your working book. And in our group, we will start with the third question. If you are ready and you have discussed the question, you might want to continue with the next question. So that means after 2, you go to question 3. And you, if you are 3, we go back to 1. So that's very simple. Anything more to explain?
We have half an hour.
Yeah. Half an hour, which is the same as 30 minutes. So we can have a good discussion, and I really hope that everybody will be able to contribute to the discussions. This group, I think you can discuss the things in Bulgarian. That group will be live streamed, and we will just be a subgroup. Okay.
And then each group has 5 minutes for report back.
Yeah.
That is where we end then.
Yeah. Okay. We also did plan some time for discussion and for questions now. Are there any items that you would raise now? Otherwise, I would suggest that we just break out in the 3 groups. Okay. Success.
So what we did, to start with, what we did is we copied the full checklist for every table just to have a look, because there are so many items, it's complicated to discuss them all. We decided to have, as an example on this table, the checklist for the malignancies, but just as an idea, which is here. It's this one. It's in English, and there are some translations also. I think. Oh no, it's also in English. The example of the peptic also. But I don't know if we have to discuss all the items. It depends what you want. It's more that we have idea of how it looks. First of all, I would like to know, because for the rest of the things you should go and discuss and ask, but what I would like to know is, because that is a little bit what's difficult, how does this land with you? Do you ever have thinking about comorbidity, or is it something from your own life, or are there concerns, or do you think when you hear this story, will say, how does it work? Can you tell us something about it?
In Greece, there are comorbidity that are very popular between patients, like divorce, like cardiovascular, and some of them are not that popular, they're not aware. For example, pregnancies and cancer. is a little more difficult, I think. And many others, like depression. So if you know to where the patient can mitigate the risk or do something in prevent.
And I'm from Greece.
Okay.
It's very important in our country, not only my country, I think for our country, pharmacovigilance. The patients don't know the pharmacovigilance. And one must do about this. And it's very special. It's very important. In my country, sent a yellow card. I don't know in my country. And all patients must film. Must film and problems. But most doctors they don't do this yellow card. No.
And the patient can report
it. Most of the I am sad.
Okay.
Most of the doctors don't use this. They use it only if something really serious happens.
Okay.
And how we know?
For example,
PARE.
Yeah. Okay.
Yes, but how we know what is serious or not?
Patients and users can report themselves to the national authority.
For when you have side effects of medication, that is what you're talking about.
For us, they don't allow us because doctors have to tell that this is a side effect from the medicine.
Yeah. Okay. So deciding what is the cause of your symptom is something of the doctor.
On my occasion, it was I had intracranial retention. Okay, and they don't inform the medicine because they are saying that no, this is not for medicines, but actually the neurologist is saying it is for medicines and they can't medicines. Okay, but nobody is actually admitted that it's side effect.
It's very difficult for the patient to go in and fill this card.
Yes.
And now in my country we try to have two cards for the patient and for the doctors.
Okay. Yeah.
And for the patients more easily.
Okay.
Feel and help patient to do it.
Yeah.
Yes.
Yeah. That's one of the options. Yes. And how is it in this side of the table? Is comorbidity something that is alive in your country, that is talked about, that is?
I think it's still comorbidity is still a strange word. It's not so often, and you have to be very careful if you are explaining to the regular people what is this. Sometimes they are so closed and they don't want to accept some new words or some new expressions. And
so the wording is one of the important issues to consider.
Yeah, you have to find a way to explain.
Exactly. Yeah. Do you want to add something?
Well, in Portugal, we don't talk about. We don't talk a lot, but we talk in the patients groups and in the patients organizations. But it's not a buzzword, so we must do a lot.
Yeah, it depends. When we talk about comorbidities, you start talking about the side effects of the medication, which can be part of it, but I try to explain that there can be other comorbidities, but when we want to do something to patients with this, and the word comorbidity in itself is a problem already, then that is where it starts. I think.
It's not very user-friendly.
Yes,
exactly.
There are some comorbidities that are going to happen because of the age, because...
Yeah, of course. Yeah.
But there are also some that is going to happen from the first disease.
Yeah, exactly.
And some from the side effects. So are three
Exactly. Yeah.
Very
And
complicated.
the idea, actually, because I think I forgot to say that, but the idea was at least to make it part of comprehensive care. When you talk about person-centered care, it's more than simply looking at your disease and things that are close around it. It's broader than that. Do you want to add something?
Yes, my name is Susana. This is my first experience here this year. I'm from Spain. And we talk about this problem because in my case I work to lupus. And we have a lot of problems with arthritis and with a lot of organs, and it's very important because we have problems with the doctors, with the medication, because the secondary effects is a very big problem for us, and we work in this camp. It's very, very important.
So it's an issue that is discussed.
Very difficult because, but we work with mainly we are people with a chronic disease. This is the most important thing for us. But it's difficult, yes.
May I raise a point? There are comorbidities that connected with RMDs. Some of them are rare, some of them are common. Should the patients be aware, even for the rare comorbidities, or they will raise some anxiety? And it is much different when you have the juvenile RMDs, because the years of treatment, the years of the disease, it adds a lot of things.
Very long.
It's totally different with some adults when they develop an RMD. Because I have a juvenile, so it's like 30 years living with a disease. It's totally different than living with it like 5 years or something, or just being diagnosed. So what should the patient be aware of? Each and one of the comorbidities, or just the common?
Yeah. You know, that is the issue when you look at malignancies, for instance, because actually it's not that that having a rheumatic disease increases your risk of malignancies.
Try and inform a parent with a child, with a young patient with an RMD, that his child is going, maybe, to develop a malignancy. Who's going to take the biological drug?
That's not how it works. But that's not the issue, and that's important that you bring it in, because that shows how complicated it is. The malignancies are only in this too, because in some countries, for instance, the convener of this project was a French rheumatologist, and he said in France, women are not screened for breast cancer when they have rheumatic disease, because they are considered going to the rheumatologist.
Well,
in the Netherlands, the public health system simply takes care of that. So there is the issue not present.
In USA, where I have treatments and they have the surgeries, every time that they replaced a joint or something, they checked everything for malignancy.
Okay. Yeah.
So I don't know if the standard procedure is done in Europe, but in USA they're doing it.
And every rheumatologist, because those are international guidelines, they check for malignancies before starting a treatment, for instance. So that is not the issue. It's more, and that is, I think it's an important thing that you brought in. What should be in the tool? Finally, what should be communicated to patients? What is the role of patient organizations in this? How can you help people to be aware of things they should notice and should watch for without? That's the big thing. I would like to simply have the question, because then we have our point, and we already started a lot of things. So the issue was, that is why we talked about a little bit earlier, and it was also mentioned this morning, that information about these things are seldomly possible in a 10-minute consultation with a rheumatologist, with a doctor, for instance. That's usually the time is too short, and it's focused on your disease and on the activity and on the medication and your lab values. So more information on what's going on, what's important, is something that patient organizations are really important in.
Can I add something?
Yes, of course.
I'm from Slovenia.
Yeah.
So when we have some seminars, we organize some seminars for people with rheumatic diseases, and one doctor says, put some questions on the paper, because in this 10 or 15 minutes we have not enough time to discuss about everything. So just put 3-4 questions. Yes, because when you are in there by the doctor, you forgot something. So write it down and ask. This is a simple suggestion.
Yeah. And it's something that you as an organization could encourage your members to. But the question is, when you want to ask questions, you have to have a little bit of knowledge, because you have to know what you don't know.
That's right.
Can I ask something else?
Yes, of course.
What is the line between an adverse reaction from the treatment and this becoming a comorbidity for the rest of the life? What's the line? That you say that this is a rare, let's say, or a common adverse reaction from the treatment or from the disease. And when it becomes a secondary disease, a comorbidity?
The line is not black and white, that's for sure.
So it depends on the patient?
No, there is, I think, I mean, this is going to a very medical question, I think, but nevertheless, it's an important one, and I agree when you look at when do you call it a comorbidity, what it is, and we discussed that in the group a lot. That is why risk factors, for instance, screening for things is in the tool, because actually the word comorbidity only says that you have a disease and another disease, which can be pretty normal in a man's life, but it can be a consequence of the disease and the treatment, and sometimes you don't even know. Do you know that you can imagine that when you have an inflammatory disease and you have limitations in mobility and you have steroids and you develop osteoporosis, that probably the osteoporosis is a consequence of. But you do not know for sure. Maybe you ever developed osteoporosis without having the disease or the treatment or limitations. So it's something that the only thing that you know is that large studies show that, for instance, and that is the case with cardiovascular disease, that it's more common in people with inflammatory arthritis, inflammatory diseases. Which doesn't mean at all that when you have an inflammatory disease that you get a cardiovascular disease. Not at all. But it only means that there is more importance to screen in order to prevent you getting from.
In fact, I think we need education. More education. We don't know a lot of things.
And how can that, because that is a little bit what is in the question, what can be the role, because information is the first thing, you have to know what you don't know to ask, but then information is not enough. And when I inform you about this project, I inform you about the checklist and the table, nevertheless it's very complicated to know for you as patient or patient organization what to do with it.
A lot of patients they don't know the right information. They cannot.
To distinguish between what is useful information. And then, how could you, for instance, how do you communicate with your members? with other people? How do you communicate? Do you have a magazine? You say you have
Yes,
meetings.
we have meetings and we have magazine.
Yeah.
We have magazine, Rheumatic, we call them, and twice per year we have its issue, twice per year. And in this magazine there are some teams which from doctors, let's say RA and so on, and of course some experience from patients. So it's very useful.
This magazine is every month.
No, twice per year. Twice per year. That's quite let's say 30 or 35 pages. Quite a good thing. Yeah.
We make also a conference.
Yeah, conferences, workshops.
We invite specialists
Management. Self-management.
Yeah, self-management programs.
Self-management,
Not working.
I don't have a good handwriting. We talked about a few things. Huh?
Yes.
Just if you don't.
Okay.
The wording in itself is complicated. What does it mean? When is the comorbidity? When is the comorbidity? And when, if that is the important thing to know, it's also something. And then you said we need education.
It's very important.
But not only for the patient, education for the doctors.
Yes.
The professionals, all.
Sometimes we know
What is Queen for?
more than doctors.
Yes, it's true.
A lot of doctors they don't know how to speak to the patient, how to communicate with them.
So you think doctors need education in communicating with the patient?
Yes.
Yeah, in communication also about disease
But also
itself.
between the health.
What did you say?
They, doctor, they have to think about the communication, but also some of the regular doctors, they don't know enough about disease, our disease.
Yeah.
This is the problem, knowledge.
And then you mean the not rheumatologist.
But also between the physicians. Let's say osteoporosis affects orthopedics, so the rheumatologist has to speak and be in contact with the orthopedics.
And the rest of the health professionals.
Yes.
And not only doctors, nurses, physiotherapists, acutherapists.
Okay, so these are the things I think that we mentioned a little bit. Do you miss something from what we talked about until? No, it's okay. This is a little bit what we have.
Pharmacovigilance is in education.
You said
We
something
must,
more about
pharmacovigilance. Pharmacovigilance.
About the adverse reactions.
Yeah. Do you consider that?
I don't know, maybe it's
somewhere under
yes.
education? So that means really the
One must
focus on
understand
the working of the medication and the side effects.
About doctors,
Yes.
about doctors, I think that we have a problem with the general practitioners.
Yeah.
Sometimes it's very difficult when you go to see the doctor and then they don't know.
That is, I think that is the knowledge that
Yeah.
you also
Yeah,
get.
they don't know enough, yeah.
Is that what you mean? That's the lack of knowledge in general practitioners about your rheumatic disease
And comorbidities.
and treatment. Pardon?
And also comorbidities associated with rheumatism.
Okay.
From the GP.
From the GP. So the lack of knowledge of GPs of the rheumatic disease, but also the treatment and effects and side effects, I think, and comorbidities. Okay, when you go back to what we were talking about, how you can, in your country, a patient organization can be helpful in, for instance, informing members,
Self-management
how
program.
you can support that.
Self-management program.
Yes. Yes.
The first is self-management. The other with many with the conference, magazines,
Newspaper. Interviews on the television.
We have a professor team.
With media, yeah.
I think the major problem is to bring health professional doctors to persuade them that they have to inform patients about all the side effects and all the rest of the diseases that may happen. This is the major problem, that they have to inform patients and they have to admit that this maybe happens, but that they have to leave you, okay, for example, for the medicine, to choose, do you want to risk it or not?
Okay.
For example, for the medicines.
That is what was presented earlier, the shared decision making, decision aid idea.
Yes.
Yeah, that's it.
Do you, simply for my knowledge, because I have to write down, I think, a few more comments of you, but just for my knowledge, do you work or have ever contact with nurses or other health professionals in your?
Yes, we have. Eliana has a professor team, so we cooperate and we speak each other for all. I think it's the first step.
Okay.
In Cyprus, in the doctor office, we don't have nurses, so we can't do anything with nurses because government don't use nurses for people with RMDs in the normal doctor office.
Yeah.
So it's not easy for us to make something with nurses and then to go further. Now we are planning to push government to use nurses in the doctor office, and we will be collaborated with the medicine university for nurses to establish an education in their program for RMDs.
Okay, that's great.
We are trying.
That's great.
We have in Slovenia, we have once per week is one rheumatologist on the telephone, and every member can call, ask something, advice for 2 hours per week.
Okay.
Yes.
So
This is a good idea.
Free consultation.
Yes, you can ask everything about Rome.
Okay.
Yes.
And do you know if it's used?
Yes, full of, yes, sometimes more than 2 hours. But we pay this. I mean, our association paid this doctor.
You pay the doctor
Yes,
to
yes.
answer all kind of questions and concerns.
Is, because, you know, when the people are at the doctor, he can ask something. But sometimes he forgets something, and it's better. And then call her, and that's it. It's a good. I think that's a good idea.
In the association, when we are in the south of Spain, last year we began a campaign to explain all the province, because there are a lot of villages where people don't know about this. We organized conference with doctors, with nurses, and they talk about the exercise, about the medication, about the treatment adherence, adherence medication, and it's very interesting. We began start last year, and we complete all the province in this sense. It's very interesting. Because we fortunately live in a big city, but people don't know, and they need information about this. And on the other hand, we work with the National Federation, and we have the possibility, because doctors work with us, and they can explain everybody about the province and answer the questions, and it's very, very important. Very important. Also, a magazine, information every month.
Information really is key.
Conference. I think that nurses, the work of the nurses is very important, because they are very close to the patient. And in this sense, we are working with this now.
So you have experience with that?
Yes, but it's important because a lot of people live in another in a village, and they
simply don't know.
Yes, they need information. It's a very important project, and I think that it will be very positive. Yes.
There was something I thought about that I should write down. Can you help me, please? Because we have, I think the information part is key, and you can do that on several ways. A magazine is used frequently. A telephone consultation, for instance. Do you think, that's just a question based on this comorbidity story, do you think that awareness of comorbidity and certainly checking, screening for comorbidity should be something for patients, or do you think that it should be more for the health professionals to take care of?
Well,
what do you think of? Can you consider a role as
both?
Yes.
All we need help.
Kind of joint.
In Portugal, like in Bulgaria, we have a few rheumatologists. So, and some of them don't specialize in these questions. Like other diseases that could be a problem too with a chronic disease. So it's very important to educate and to inform also in the universities, in the medical schools, in the nurses schools, but also in the patient organizations, because we all must do our work. So
and preferably together.
Yes.
That's the
Should
thing.
do a campaign raising awareness on risk factors associated with the disease. Because most people don't is not aware of what are the probability of other diseases associated with the RMDs.
Okay, yeah, okay.
And we need good information because we all have the web and the net, and the global information. Probably some are good information, but some are not.
Yeah.
So
that's what you earlier mentioned. Also the distinction between what
The
is good and
yes.
wrong information.
Yes.
What is
Patient afraid to ask again.
Pardon?
Afraid to ask again.
The patients,
Okay.
yes.
Yeah. Okay. Yeah. So there could be a task for, and that is what Christina also mentioned in the panel, that when you visit a physical therapist and are doing exercise, you can talk about it. When you do hands with the occupational therapist, you can talk about it.
we could have a web platform where all dialogue about this.
Yeah, yeah.
In Portugal, we have the
We have a bigger association that gathers several patients' organizations and even pharmacies, and it's a platform for dialogue in health.
Okay.
And we can also use that kind of platform to spread and disseminate.
Yeah.
And you have also a website?
Yeah, they have also a website.
Website is very important, especially for young generation now.
Yes.
Yes. Magazine.
May we add something? In Greece, we have the preventive activities. Let's say we walk and we do exercise in order to prevent cardiovascular diseases and osteoporosis. So, preventive exercise, preventive activities generally.
And are these preventive activities, are these focused on people with RMDs?
Yes,
or
yes. Inside the organization. Or in cooperation with...
The cooperation. And every year we do
the Walk for Life.
The Walk for Life.
To raise awareness.
You can also imagine that some of the issues that we mentioned are really also really relevant for the general population. For instance, the idea of enough exercise every day, that's good for everybody.
Smoking, drinking.
Exactly, those are really generic lifestyle in which general sense and even government can have a role. I think we have a lot of issues already. Is there something that you miss on this until now? So try to set risk factors. That is what you said, right?
Risk factor.
When you now consider what we discussed, looking at what has been said, for instance, you said, do I want to know everything from the very beginning that ever might happen in my life? Which can also be a generic question. I mean, that's for everybody. Do you want to know how you will do when you're 60 or 70? Maybe not.
The parents, yes.
Pardon?
I think the parents, if they have a kid with RMD or with any other disease, they have to know the major risk for the...
In clinical trials, we call it the patient's right not to know.
Exactly. Yeah.
And they have the right not to be informed. Yeah. They choose in order not to be anxious.
Yeah.
They have the right.
Yeah,
exactly.
But what about when something happens?
But that's an important issue.
And they don't realize from the beginning that this happened. Parents. Yes.
They live more freely without being aware.
Yeah.
We are all gonna die one day.
It is the patient's choice. It's the patient's choice
Exactly.
to be
I put it
or
like
not.
this.
Yeah, we have this project where you know what it's okay.
The patients have the right not to know.
Not to know or not to know.
It's a big question.
It's a big question. Yes, and the issue is how can you find out? I mean, when we consider, come back to our checklist. When we consider a checklist like that, I feel in the practice I work as a rheumatology nurse. I work with people with inflammatory arthritis. We pay attention to cardiovascular risk, and even then I find it very difficult to communicate that. Whereas cardiovascular risk in the Netherlands is pretty also a generic issue which is discussed frequently. But nevertheless, I feel it difficult when somebody has an older patient who has gout, who has bad renal function. I calculate risk, cardiovascular risk score, which is really high, and then what can you do? How do you communicate that? It's very difficult. But when I want the patient to choose finally in the end if he or she wants a certain treatment, for instance, we have to discuss it. That's the difference.
You need psychological support from a psychologist.
Yeah.
To communicate.
Communication, that is key, I think. How, and really learn how to
talk about it.
Yeah, as patients, how to communicate what you need, what you want, and as professionals, we said it of the doctor, but I think it's more generic for all professionals also, how to communicate and jointly find out what is needed and what should be discussed and what shouldn't be discussed.
So EULAR should step in here with points to consider and try to inform in a lay version, very easily and in a lay version about the comorbidities, and should you be aware or?
Yeah. And thinking about the checklist, because that is some of the issues that we really don't know. When you have the checklist and you want, because that is what, for instance, the French rheumatologist said, then we make a patient-friendly version. I don't know how I can do that patient-friendly, because what would be in it then? Do you have an idea or suggestion of how I can inform you about potential risks if you want to, that you have the choice to be informed anyway, and then that you have the choice on which factors you want to be informed and how extensively you want to be informed.
The truth is one. You can't do it gently.
That's right.
Truth is hard. Yeah.
But it's the truth.
Yeah.
If you want to be informed, you should be informed. Either harsh or gently, the truth is one.
I think
a lot of questions.
I think that they have to have some psychological support, but health professionals Okay, they have to be educated by psychology how to present the results and how
to communicate.
With patients and how to learn to understand person that is on the next on the other side.
And that is on the very personal level.
Yes.
And perhaps
always is a person. That is
on the really one-to-one level. And for the group level to say, right? That is more what can you use as information? It's I think more about what can patient organizations do together with.
The information should be dynamic because all these in chronic disease are also dynamic. So also the doctors and the nurses and the patients need to know about it and have a continuous training, not just education but training, all lifelong.
And an easy language.
Yes. Yes. Lifelong training about these questions and issues.
Let's see. How far did we answer a question? How can organizations develop relationships with natural nursing groups and work collaboratively with them in developing educational initiatives?
I talked before, we are trying to make collaboration with university nurses or with the community of nurses in order to provide the education on RMDs.
We are collaborating with the National Health Professionals Organization and trying to work together to try to establish rheumatology consultation by nurses.
So you have the National Health Professional Organization. And do you have it in place? I don't know if there is a... What do we have? The National Health Professional Organization.
Rheumatology.
Rheumatology.
Yeah, I think we all have it in all countries.
But it's really this comorbidity story is really complicated one, to see how you can communicate that to your members.
It could be easier if the questionnaire developed by all the professionals and patient organizations in order to be more easy for the patients. Some patient organizations have more knowledge of how to approach the
Sure, but that's surely what should happen. I mean, and I can produce a patient-friendly version. No. It's really something that you have to do with a group of people and certainly be aware of how you call, how do you, what jargon do you use. That's a little bit also in the slides that Maarten presented about the lay version. Then you can consider that you simply do not want to have checklists like this, even not in the lay version. Maybe accessible for people, but not in your magazine, for instance.
There's a checklist. There are some issues here that cannot be understandable. They are not supposed to be. No. They're very professional.
Yes.
This one, I think, is very understandable. It's easily understandable.
It depends a bit on the topic. Yes, I agree. But in the checklist there are really complicated things, and even things that I had to look up. I thought, oh, what's this? And we were in a group of
professionals of rheumatologists, and everybody was sort of, what is this? What is exactly meant by this? Yeah. Well, I think we did a lot of work. Maybe we can continue to the next question. Yeah. Okay. We already talked a little bit about it.
We had for some. For most of the common RMDs.
Yeah.
Like psoriasis and
AS,
tonsillitis, RA,
lupus, osteophytes,
sodium, lupus now, sclerosis.
And every 2 weeks or 3 weeks we go to the hospital and give it.
And the educational material, that is information about the disease, about the treatment.
2 points, yes.
Yeah.
Exercise.
Pardon?
About the exercise.
Okay.
How it's important.
This is very important.
We have the magazine every 6 months. We have a magazine.
Yeah.
Every 4.
Okay.
We have groups of each disease.
Yeah. I'm just looking at, because I lost the time a little bit, I think that we should have our we should end on this because we should have our group. Well, very short report from our subgroup. If I forget something important to mention, please add to my Yes, okay. The first thing was that people feel that the wording of comorbidity is really complicated. So, if you want to do something with that, we have to consider how to call that. That's really important. Then, the main issue was education. Oh, sorry. I'm sorry. Just a short repeat. The wording comorbidity is really difficult. What does it mean? It's really pretty meaningless, so we have to discuss about when you want to communicate it, how you call it. And a second really main issue was education. How can you inform, and information is one of the first things to do in education, but it's really, we think that it's really difficult to educate, to inform people about this complicated material without additional information. And we talked about collaboration. That was our big question, collaboration between patient organizations and health professionals such as nurses, which is really an important one, to have a lot of medical input or background input in finally translating this in a kind of wording that is understandable for patients. And then there was an issue about, and what do you inform people about then? And one of the things that was explicitly mentioned, and is really a nice thing to think about, is that patients have the right to know, but patients also have the right to not know. And do you want to know? Yeah, that is what was mentioned, so I say it here. Yeah. So that is something to consider in the communication, how you should report and inform everything. Maybe you should consider a kind of layered version of information. What also was considered is communication in itself is really important and also complicated. Complicated on a personal level, to know what is information that is reliable, but also that you want, that you need. You need to know what you don't know, to ask what you want to know, and to distinguish between good and bad information. And then it was mentioned that many of the patient organizations work with preventive programs, and that will fit a part of the information, I think. For instance, when you look at the comorbidity of cardiovascular risk, because that in the end might be considered as pretty generic. I think these were the key issues of our group. Are there any questions or comments on this? Okay, we continue. Nicolas?
Thank you. It's my honor to give a feedback from our group. First of all, would like to say that this comorbidity screening tool is a great development of EULAR and will help to educate patients and help them make more educated choices. But as everything new, they should be informed about its existence. So this could be done by preparing paper materials, flyers, transparents, which could be provided in the praxis of rheumatologists. And they could be accessible for the patients. They could read information about this tool. And also, as Ivan said, the terminology in the tool should be kept as simple as possible, but sometimes this can be avoided. So probably another education materials could be needed to explain the difficult terms, and this could also be accessible on a web-based platform, and all this information to raise the awareness of the patient. And for implementing this screening tool and these screenings, for the first time, a mass screening campaigns could be organized. And with these mass screenings, patients will learn about the existence of this tool, and later on, this screening could be performed on a regular basis, like the DASCO, and could be done on visits. Also, for a better choice for his health, the patient's family could be involved in the process, of the screening tool to help him assimilate the information and help him with the choice. Also for the 21st century, it's good to develop an app for modern technologies like smartphones, tablets. This app could include an example of the form with the checklist itself, and some materials and extended information about all these checklists. And it could also remind the patients periodically about the need of it to be performed. And this this form for our group is somehow like a passive form for the patients. The patient is being asked some questions which are ready. So we could introduce the patient to make records in a diary. So when he goes to the praxis of the rheumatologist, he could report his diary and make sure that a staff will not be forgotten when he arrives at the praxis for the comorbidities. And also, the physician should educate his patients about the comorbidities. Of course, considering the patient's condition in order not to provide the patients with excess information and stress him out. And also, the tool should have some extensions considering the RMDs, which can involve another organs or systems, and to make the patient more aware of all the other complications which can appear in the disease. And the conclusion is that the tool itself is a good way for improving the education, but also an education is needed for the tool to be implemented.
Okay, thank you very much, Nicola. Are there any questions for Nicola? Additions from the group? Okay, thank you very much. Well, I think we had quite some overlap also with your group. We had a very various group, everybody coming from another country, and we first made a small round to ask what do you think about comorbidities, and is it an issue in your country? And we found out that not many organizations do have experience with comorbidities and actively do something with it in their organization. So everybody agreed that there is a need to raise awareness on the issue of comorbidities. And we had actually one organization, which is the ASIF umbrella organization for people with ankylosing spondylitis, who have some concrete plans that they consider to start a campaign around comorbidities. So that was very interesting. One of the reasons that we thought it's important to pay more attention to it was brought forward by raising that not all patients are aware of the relevance because they can have the risks without noticing, because, and we call this a little bit like silent symptoms, For instance, sometimes high blood pressure, you do not feel it, but you have a risk if it's not monitored. So then we had looked at the question of our group, and I tried to make it a little bit into two groups of advantages and disadvantages. Let's start with the barriers that we see in working on comorbidities. Immediately the question was, who fills it in? Health professionals often have no time to do this, certainly not a 96-item list. We also identified that the terminology is still quite difficult for patients to understand. And if you only look at the document, it doesn't say why it is important to fill it in. So the key message, why it is important to pay attention, should be acknowledged somewhere. And then the last thing that we mentioned was also, are health professionals open for this type of tool? Because they should do something with it. So as a patient organization, you can start promoting the tool, but if the health professionals are not going to give it a follow-up, then it doesn't make sense. And we first have to work with the health professionals that they also see the necessity to do something with it. And then we also saw that there are some advantages. The instruments have actually only closed questions, so it's easy to fill in. It could be part of self-monitoring, and actually it should also be part of self-management courses. And then to overcome some of the barriers, the suggestion was also made, like your group did, to think about a glossary, so a list of explaining terms, to make something like a lay summary. We also thought about an app, and also about involving health professionals in setting up presentations about comorbidities. And maybe EULAR or PARE could also provide and help with giving or developing something like a PowerPoint slide set. What we also thought is that if you do this, you need to think about the feedback that you give to patients. So patients fill it in, but do they hear anything back? And if they know that you have a higher risk, then you should also give some suggestions how patients can deal with these higher risks. So what are the recommendations to do that? But also if you don't have a higher risk, you should give some recommendations for how to prevent that the risks will occur. So, and then in the end, we identified that actually what is most important is communication. To introduce it well, it's important that patients and health professionals have a good dialogue about these risks, and that because it's complex, the key is really in communication. Okay, and then we address the other two questions, but that's quite also similar with what you did. So, any questions from the other groups about this? Otherwise, I think we can wrap up. And by saying thank you all for being here, for your active participation in the breakouts. I hope you learned a little bit and also find it a little bit of fun, because the conference should also be a little bit of fun. I think you all deserved a nice lunch that we organized, so that's good. We will bring some statements to the meeting and ask people to vote on this. And we will base these statements on what you have brought in. So be prepared to also vote and say whatever you want. that was it. Okay. Well, after the meeting, after the lunch, we meet in this room again. I think I have to look.
Yes.
What time? Okay, so 2:15, 2:15, we will be back in this room. Enjoy your meal.
Okay, thank you for your report.
It was a hard job to find people. There was very nice people, but they were very... It was the best. Better It was very... It was very elegant.
The quality is more important than the quantity.
In the end,
They need to switch me on. Little tweet every now and again. Good afternoon, everybody. Judging by all the nattering, you got to know each other over lunch, which I hope was tasty. This is otherwise known as the graveyard slot, so I reckon that's why they have an interactive session. So this is where we present the feedback from all the workshops, all 4 workshops, and we get you to vote. So if you were in Dublin last year, you'd remember these 3 cards, which were kindly supplied yet again this year, because I'm sure you all left them at home. So each workshop leader will present what they went through in the workshop, and then they will put up a series of statements. Hopefully some of them will be nice and provocative and controversial, so we won't have green all the time. But if you agree with the statements, you put up your green card. If you disagree, you put up the red card. And if you're kind of sitting on the fence, say you're unsure, you put this up. So we don't want to see too many of these, okay? See lots of these so we can get some interaction. So you have to pay close attention, because I'm going to pick on somebody as well to ask why they voted a certain way. So that's just to keep you all busy. But we're going to go straight into the feedback, because there isn't a huge amount of time, and we've got 4 workshops to deliver. A very, very busy day already. So we're going to go straight into workshop number 1, which is Giovanni. Giovanni Lamura is a social gerontologist, and he's from the Italian National Institute of Health and Science on Aging. So basically, Giovanni, you're going to talk to us about your workshop, which was identifying ways that support could be made more available to everybody with RMDs. So Giovanni, do you want to take us through your feedback? Over at the lectern, yeah. And then get into your controversial statements.
Yes, thank you very much. Yes, we had an interesting discussion in our workshop, and we had to deal with the issue of informal carers, and specifically we tried to discuss in the 3 breakout groups about the support needs of informal carers, and then aimed at developing some elements of a campaign that could be developed by national organizations in this area. And we had a lively discussion, both within the groups and then in a plenary of all the workshop participants. It is a multidimensional effort, that of supporting informal carers. And so we were challenged by reflections concerning psychological aspects, financial aspects, but also the challenges that a society has in terms of developing appropriate supports. And so it is not only a matter of training and education, but also a matter of recognition of rights and of formulating appropriate benefits. So to make a long story short, I think we tried to formulate into three sentences our core messages to the plenary for you to vote. And these are listed here, and I was told that in this exercise, in order also to make the discussion possible, our messages should be proposed also in a form which allows a discussion to take place. So the first one concerns this issue. All patient organizations should provide education, psychological, and peer support to informal carers. Now,
okay, so now we vote. If you agree with that statement, stick up the old green. It's kind of like a motherhood statement to start with. Anybody disagree? Oh, we see some red cards down the back. Just like yesterday's football game, Gert, there should be a few more red cards there. Sorry to bring that up. The red of Liverpool. Okay, that's the last time I'm ever going to bring it up. Would anybody down the back with the red card like to explain why they perhaps voted that way? No? Yeah, just give your thoughts on...
Hello. I thought that there are going to be more red cards, so it's not red and more orange from my part, because I'm thinking more... Ideally, of course, patient organizations should provide this kind of education and so on, but I think that we're right now in the stage where patient organizations have a lot of things to do in their scope, and this kind of thing, education for people, should be done by other parties or other stakeholders rather than patient organizations. Support this education and so on, of course, but not be the leading party in this process, in my opinion.
Okay, that's a fair statement, yeah. I think we'll probably explore that a little bit later on in the panel. So do you want to read out your second statement and third?
Yes. Carers should take time for themselves, no matter what.
Do what you're told, carers. You're just being provocative now. And then, okay, that's overwhelming. Everybody, bar one or two, disagree with that. So the last statement then?
You don't want any comments from the...
No, I don't think I'll just pick one or two.
All right.
Yeah. I mean, he's only playing with me anyway, so...
So, all financial support for carers' needs should come from the state.
Now, I expect there's a lot of color on this one, and something that resembles the Italian flag, I'd say. Yes. I think we'll probably explore that a little bit more in the panel as well, because that's a nice controversial statement that we like around here. Okay, thank you, Giovanni.
Thank you.
Okay, now our second workshop leader needs absolutely no introduction whatsoever, because he's been introduced about 3 times already today. It's our president, and he's also a clinician as well. So a really, really interesting area, online tools, and something that's showing quite a pace around Europe as well, and I look forward to.
Yeah, we had an excellent group, and everyone was, I would think, very enthusiastic. And first of all, we ask, does everyone have a smartphone? Everyone has a computer. Of course, in our group, they had. There were even only 2 people who had not signed up to Facebook, including myself. And I think Dieter, right? Exactly. Everyone else had. But we agreed that this is the medium to go forward. Everyone was very excited to use the internet, and also probably we had quite a few colleagues who had generated apps, which I think are very important, because what people tell me who are savvy in this particular area, they say it will not be the computer in the end, it will be the smartphone or a tablet, because that's what most people will have. So we discussed first of all how to get access to it and how to set it up. So probably EULAR could help, at least to give some ideas how to set up a smartphone, and also how to set up a webinar on YouTube, something like this, so that we have the prerequisites. I also addressed, because I once made a mistake. We had a World Arthritis Day, and I gave a presentation, and I said everyone should have an internet access. I put forward the example of my mother-in-law, who's 84 years old, is Skyping with my daughter in Idaho, in the United States, without any problems. But then quite a few patients said, well, but this is so expensive. And then I made the mistake and said it's only 20 euros. And many patients said, 20 euros to me is already a lot of money. So we'll have to deal with this issue, because I firmly believe that every patient with a rheumatic disease needs access to the internet. either via smartphone, tablet, or regular PC. So that was addressed. And then we addressed what were the most pertinent needs. And first of all, many participants said, well, if I have the disease for the first time and I have the diagnosis, I would like to go to the internet to a trusted site that informs me about the disease and that also gives me optimistic information, because what you do not need is pessimistic, that it's a dangerous disease, that you have all kinds of side effects from treatment. That is not very helpful, because, and I know this from my daily practice, you need to raise optimism. So that was something we discussed. We discussed capacity building, which was very important, and a couple of few more items which I cannot discuss now. But we all felt that this is the way to go forward. And from the EULAR side, I would invite any ideas that you have, even if they sound very crazy, and because we want to be very innovative. So now let's go to the statement. Training skills and knowledge. We discussed time management, which is very important because some people may have an hour time, some 3 hours. Professionalism in advocacy, sharing best practice, and potentially certification, so that you have some certification that you really can do this properly. The workshop with regard to medical information, basic info, I already addressed this. Positive approach, understandable, available on the internet via smartphone, computer, or tablet PC, and of course to teach where to find the information. That is very important, because sometimes you come up with 100 entries, but what is the appropriate information that needs to be identified? Finally, capacity building, how to use social media. Working with and having qualified volunteers obviously is very important. Empower patients for self-management. Challenges are there: language, time, support, also financial issues. And I raised the question in my group, and I think that is also relates to the last statement, is would you agree that, and this is not on the list, that if pharmaceutical companies gave us EULAR unconditional grants, nothing attached to their particular drug, but just to the disease, and we get some money to support volunteers, translation, technical equipment, would you be in favor of it, or would you say, no, no way, we don't want to get involved with pharmaceutical industry at all? So maybe I can have an informal vote. Who would say that yes, if it's completely unconditional, if it's not related to the particular drug, I would be in favor to support that. So I see just one. No, not. So it's all green cards. Thank you very much. So that is important information to take home for EULAR, and we will discuss that. Okay, now let's go into the statements. The first statement, again, is not listed here. Please vote with a statement that Bayern München will be the next winner of the Champions League. Who is in favor? Wow. I can't believe it. They're all red cards. And they come from Britain. I can't believe this. What about Spain? Right. All right. No, that was just a joke. So, so I think we deserve it, since yesterday we just lost against Liverpool. But luckily against the German coach. So it's not so, so there's some consolation in it, I must say. All right. But not all joking apart. So 3 statements. Volunteer work must be professionalized. Do you agree or not? Or are you neutral? Okay, so I see some neutral, some red cards, quite a few actually, and the majority still is green. Would you agree, John? Yeah. Mm-hmm. So we want to discuss it? Yeah?
I don't think that, well, that's my personal opinion, that voluntary work should be professionalized, but would be supported in a professional way.
Yeah, that's a good statement. Yeah, exactly. So you don't have to be a professional volunteer, but you have to need support in order to do that the best. Okay, so we should phrase the question again, or Okay, with these notions, please vote again. Support to be more professional. And this is now unanimous. Okay.
It's all about
very good statement. So Nele, you have to become a politician. So that is perfect. Medical information must be approached positively, be understandable, and be available on the internet. Who's in favor? Abstains? That's much easier than Bayern München, apparently. So everyone is in favor.
Yeah, everybody's in favor, even though it's available on the internet, medical information. That's interesting. So, okay.
Yeah, we would say probably good, positive, trusted medical information.
Okay.
That's what we mean. And finally, EULAR should be teaching organizations to use social media effectively. All right, so there are some neutral votes. Oh,
okay.
Nele. What did we do wrong? You want to comment again?
Well, why don't you tweet him? Why don't you tweet him?
Well, I don't really think that specific social media thing is a task for EULAR. I think you can learn it in many different settings and on a national level. I think EULAR has more important tasks than learning us how to use Facebook and Twitter.
Yeah. Okay, but apparently you're in the minority. I think you were the only red card holder, but that's fine. No, but we will.
My career.
So when I go back to the steering committee, I will say everyone was in favor, but you were not. But since you're going to be a member of the executive committee, so we're going to have some questions, especially with Emunet. So they're going to be interesting.
So, Gerd, when you say EULAR, you mean PARE as well, don't you?
Of course, of course. PARE is part of EULAR. Oh, of course. PARE is part of EULAR. Yeah.
Just to stretch the meaning a little bit. You know?
Okay. Thank you very much.
Thank you very much.
Thank you.
So, next up we have Yvonne van Eyck-Hustings, I hope I pronounced that correctly, who's a rheumatology nurse in Maastricht University Medical Center. So, how did you get on, Yvonne?
Okay, thank you very much. Well, in our group we first told the people something about recently developed points to consider for reporting, screening and preventing comorbidities. And we also informed the group about the checklist that has been developed in that project, which was the thing that we really discussed in the subgroups. We had interesting discussions with a lot of people from various countries, so that was very nice. What we first, and I'm going to show you it very shortly, I hope you can see it. It shows a little bit the complexity of the checklist, which really is about 6 different comorbidities. This is an example about cardiovascular risk, and there are 93 items to be checked in a checklist. So just to show how complex it is. Well, finally, that was the discussion that was going on, that the wording of the list is really, really very complex, and that we definitely need lay versions. The question is a little bit who is going to develop that, and we were sure that it should be developed closely by collaboration between health professionals and patients in a joint effort, and that communication about comorbidities is really very important and also very delicate, and that patient education is really important, but that how to do that is an issue to address. We felt that the tool could be helpful for the patient education, and with regard to screening for comorbidities, we are still not 100% sure who is responsible. So that is the content of our workshop, and now I come to our statements. The first statement, and you can agree or disagree, patients do have the right not to know their risk of comorbidities. Please give your votes. Mixed. A mixed.
Nice little, in fact, it's all the reds on this side
yeah,
and the greens
that's,
on this side. How did you work that one out before lunch?
Yeah. It's interesting.
Makes
it easier to discuss.
Yeah, I know I ignored you the last time, but But you put up your red card. Is there any thoughts you have on that?
Thank you. Thank you at first for your comment on the first non-vote, but I think that is not a thing about a right, but it's more about the complexity of their disease. And I think when you tell them on a normal way, you can give them the good information. So I think that everybody needs to know that their illness has a comorbidity issue.
Mm-hmm.
And I think that's also a good thing for saving money and saving quality of life. That's my main point.
Mm-hmm.
Okay, thank you.
Okay, next. Our next statement is, in my country, health professionals are not interested in screening for comorbidities. Do you agree or do you disagree? Disagree.
Wow. That totally stuns me, to be honest with you.
Yeah.
Would anybody like to offer... Oh, we got the young PARE crew, so I'm going to pick on some of them. Wendy, or Linda, one of the... form an answer between the two of you. Why is that your perception in your country? You can do a duet if you like.
So your question is if it's...
Well, you voted against that statement, so
yes.
They're not interested.
So they are interested.
So you disagreed. Sorry, I beg your pardon. I've got it mixed up.
Yeah. Yes, I think in the Netherlands they are interested and they do a good job in screening.
Okay, but there were quite a few Greens there as well. Sorry, I wasn't paying attention to my own question there for a minute. Any Greens like to expand upon that? Because, we have somebody there in the back. Would you like to just give your name and country so that we know where to go next?
My name is Snezhana from Bulgaria, and I voted with Green because we don't have such a good and explicit health professionals. That's why they can't be so interested in screening, because we don't have rheumatology nurses. We have nurses, but they are not specifically educated as rheumatology nurses. So we are in shortage of such health professionals who can do that screening. That's why I voted.
That's a very important point here.
Okay. Okay. Next one. And our last statement. Specialized nurses should support patients in the screening and reporting of comorbidities. Who agrees or disagrees?
Okay. I noticed some people aren't voting. Have they not got cards? Or anyway, that was overwhelming.
Yeah.
Yes, agree.
Okay.
Thank you very much. Okay, our final workshop was delivered by Simon Stones. Now, Simon, apart from picking me up in his taxi at the airport yesterday very kindly, is doing a BSc in Biomedical Sciences in Manchester University. They also wear red, but they're not as good as Liverpool, apparently.
Thank you. We had a really interesting workshop, and one of the first Young PARE workshops that has been led from the start by young people with RMDs. So we had some really interesting discussions, and really we wanted to identify the barriers that organisations and individuals across Europe felt would prevent them from setting up a youth organisation or sustaining a youth organisation. And we prioritised the barriers that we came up with in the group, and then we split up into 3 different groups to look at solutions to those barriers. And we had a really nice case study as well from Sylvia in Italy to really emphasise through the knowledge transfer programme how a youth group can be set up with support of other organisations in Europe, which is really important that we don't reinvent the wheel and we work together. And the 3 key challenges that we identified were the stigmatization associated with RMDs in young people, and that it's not just an old person's disease, and the fact that childhood onset RMDs are quite different to adult onset RMDs. The second was motivation. Why and how would we get young people to be involved, and what is in it for them? And we discussed the needs of individuals, which differs. We identified the educational needs of the people to realise that they can get something out of being part of an organisation. And we looked at the use of social media, as well as face-to-face intervention support as well, because some people might have social anxiety, and the use of social media may help them to be more comfortable before we started in a face-to-face environment. And we highlighted the use of our new virtual knowledge centre, which is hosted by Young PARE, to act as a facilitator in helping to engage organisations across Europe to work together. And finally, it was finding and retaining young people. Finding young people to be part of the group is difficult enough, but to keep them engaged and keep them coming back to the meetings is really important. And we identified the need for a coordinator to really support that process, and really that a young person with direct experience of an RMD is really important in that process. So we've got two statements. So if you'd like to vote, so the number one is a youth group can be started and sustained by the youth only. Age is just a number, it's all about personality. Do you agree or disagree?
Well, that's an overwhelming yes, but typically Irish. Sinead has thrown in a red card, and I would really like her to explain herself.
Well, I just feel, no, as a young person living with an RMD, I've seen how difficult it is to get young people involved. In Ireland, we have 12 branches throughout the country of people helping other people with arthritis, and I've seen people won't get involved unless there's somebody in a similar boat in them because of the stigma, the fear, you know, whatever section of, you know, emotion they're at with their own disease. They can't relate to somebody who's not in the same boat, who's of the same age group of them. And that's just my personal opinion, from what I found.
Well, I suppose that's the reason for setting up a group in the first place, isn't it? Does it? Okay, we have another comment at the back. Can you just give your name and country as well, please?
I'm Ella Vine. I'm a board member of European Network of Fibromyalgia Associations and Chief Executive of Fibromyalgia Action UK. I voted this colour because I think that if we say that a youth group can be set up and sustained by youth only, I think we're cutting off quite a lot, because what I truly believe is that anyone should be helping and campaigning for the issues that we care about. This is example of the youth group for RMDs, for example. So even if somebody that is not young or does not have RMD can still be the voice, and if we want to achieve a change, we need anyone to be involved, everyone to help, because if we only have the voiceless and the weak campaigning, it's very difficult to achieve a change. And I think everyone needs to be involved without the feeling of, oh, I don't belong to the group because I'm not young.
That's a very good point, yeah. And does come up from country to country, I think.
And our second statement is disclosure is a bigger problem for children and young adults than it is for older people with RMDs. Do you agree or disagree?
Okay. Mixed bag there, Simon. Did you expect that?
Yes.
You did? Oh, you
Slightly,
sought
yeah.
a mixed bag. Diana, would you like to give your perspective on that?
I think disclosure is a problem at any age. If you're young, it has obviously problems with university, school, or whatever, interactions with other people. If you're older in an established job,
it's a huge issue in case you may lose your job, you wouldn't be able to pay your mortgage, you support your family. So I think disclosure is a really big issue for everybody.
I would tend to agree if I was voting, if I was allowed to vote. Okay.
Thank you.
Simon, thank you very much for that. Okay, just in the interest of time, I mean, I kind of half thought about asking everybody a separate question, but there was quite a theme coming through all of that. And the theme, well, one of the themes coming through the workshop feedbacks was, you know, the roles patient organizations play and the role and responsibility of EULAR. And this comes up every single year. Is it EULAR's job? Is it the patient organization's job? Is it the patient's job? Whose job is it? And when we talk about the responsibilities of informal care, we talk about social media. I'd like to just throw it to the panel about, you know, and maybe so you mentioned this, Gerd, and this is the unique thing about EULAR. It has 3 key stakeholders all working together. But in some ways, maybe that puts significant pressure on the organization to do all things for all man.
That is certainly true, because it adds to the complexity and just to the labor. I mean, it's a much more amount of labor for all those involved. Nevertheless, I think we can only advance the field of RMDs if we all jointly work together. Colleague, and he made this very clear. I think this is a prime lesson that I take away from this conference as well. And so in order to accommodate this, we will launch the School of Rheumatology, where we have one roof, one big school for everyone, but with separate classrooms. And so that every group is able to fill the classroom with the needs that they have identified. So they're basically completely free what they put in, as we discussed in our group, the contents and what they like most, and there will be certain priorities. But with this classroom concept, I think we will advance the interaction tremendously. Obviously, there will be leaks between classrooms, and we will already discussing how to best accommodate this, because it needs close interaction. But I think this will be hopefully a very good start in a completely new era of information management. And I think we are there already. I think the internet, the online information will change our medical profession tremendously in a way that we don't even envision yet. So with cross-border care, with cross-border consulting, and so on, information. And so I think EULAR hopefully is at the forefront to really see all these challenges and to meet them, hopefully.
Yeah, I agree with you. Giovanni, have you any thoughts on that? Because I think your last statement there about like financial support and who should offer it, I left that for the panel, because I think that was quite a controversial statement which we were looking for. And you know, patient organizations do come under an awful lot of pressure to produce and finance services.
My thought on that is that the situation is very different from country to country. So I know areas where sources come from different providers. The state, but also non-profit organizations are very good at raising funds through private foundations. So that's my thought. I mean, I would dare to suggest, look around yourself and see about potential sources of funding and go to them, because you might find positive surprise sometimes.
Okay. Yvonne? Certainly in the area of comorbidities and what role a patient organization can play in educating.
Yeah, that's true. And I must say that finally, in the end, a lot of things came up in the different workshops, apparently. So what we talked about the jointly responsibility of health professionals and patient organizations, that's really important. And I think the discussion should not be who is responsible, because I think it's a joint responsibility. But in the end, when it is about achieving things, you need facilitation of developments, and sometimes it is with money, and sometimes it is with a kind of vision or strategy. I think that's the major point.
Okay, thanks, Yvonne. Simon, have you thoughts on, I mean, particularly with regard to youth and young PARE, do young PARE feel supported within?
I think young PARE have grown enormously over the last 12 months, and to a point where we feel really integrated in PARE as well as EULAR, so that we can better represent the voice of young people. And in terms of whose responsibility it is to educate people, it's everyone's role. People with conditions, family members, health professionals and industry. But at the same time, we cannot force that education onto people. If people are in denial, with as much will in the world, you cannot drill that into people. So it's having the opportunity for that information to be there and accessible for people to access.
Okay, well said. Okay, can I just, on your behalf, thank the 4 leaders, the workshop leaders. It takes an awful lot of time and effort and preparation and personal time as well to do that. And also thank you for the interactivity, a little bit of fun as well on it, which has to happen. So you were great. I was hoping that you would interact, and you certainly did. So can I ask everybody to give a round of applause for the 4 leaders. Now, I think we're doing pretty well on time, Esme. I got you around to about 3 o'clock. So the next, I mean, Gert, you said this is a packed agenda. By God, it's pretty busy, isn't it? With a very early start. So I know some people are feeling tired. I think the next hour is important as well, because it'll get you on your feet, get hopefully a little bit of fresh air. But you must visit the best practice fair. So we have 3 rooms set up. One is with people with RMDs, the other is for the general public, and others for policy makers. So you can see where the rooms are, and I'd encourage you to visit all 3 and have 1 vote within each room. So the whole idea is that whoever receives the most votes gets to spend a bit of time up here presenting. So we need you back here. We need you back here by 4:15, so that's 16:15. So you've got an hour and 15 minutes. Thank you very much.
Razmišljao sam o tome da vidimo da li će nam uopće trebati. Ako jako duboko možda nam neće ni trebati. Pričekat ćemo s tih sekundi.
stavi slušalice u uši odmah. Ti si u drilu, ti namještavaš ton. Ti namještavaš ton. Stavi slušalice u uši. Ti si u drilu, ti namještavaš ton. Ti si taj koji si u drilu, ti namještavaš ton.
Darko, pričaj. Darko, trebamo audio test, Darko. Trebamo audio test.
Ti namještavaš ton da nam se ne poklope frekvencije, tebi da se ne poklope frekvencije. I tebi se ne poklapaju frekvencije. I ti si... Tebi je poklopena frekvencija. Tebi je poklopena frekvencija. Tebi je poklopena. Šta?
A šta je sa ovim? Ne čuje se na slušanje. Zašto ne čuje slušanje? Nešto je mutirao kad nam je pokazivao play, play out, kad se pokazivao, onda stisnuo. Desni skroz, prozor tam. Nešto pričaj. On dosta glasno priča, pa onda...
Ti si taj koji pečeš struda na HŽ-u. Tvoje djevojke rade pekmez na radnom mjestu. Oni imaju te velike radnje. Te velike radnje. Pojma pekmez, šljiva pravi domaći, od drenka pekmez, cure na poslije. I sad si u Max TV i traži sam kabel koji iz iPhone-a dalje, si mu šaduri. Muke grilu od ovdje, sve živo, ne živo. Max TV prethodno za balon, za stavno. Svi imamo Max TV prethodno. Šta nam još treba? Treba nam samo veliki kabel da se možemo gledati televizu i non stop umjeti držati. Šta ga sad će Karol će sad rješavati mobitelove koji će igrati Ivani i onda će Ivana imati potpuno mi je poticao
Ovo je dobro, a sad će ovo...
Aj sam provjerio ovo, sad nije sigurno.
Ajde, nemoj sad raditi. Provjerio ti u eksperiment. Znači imamo samo dva prijedloga. Ili ćemo koristiti ovo ti nije previše ili ćemo otići na smeće. Nemamo više biti. Ja bi ovo. Ok, onda to. Digni, idemo. Ok, maybe we can bring... Few minutes. Nema više eksperimenta. Ti odlučuješ i sad ti uvagi. Zašto ti tresi? Zašto ne danas ne? Nije stek. Da, počne najbliže. svoj čiko desno da se mora da ode. To ćemo kanal tražiti. Ako dolazi? Ma ne smeta, to je super, malo motion izgleda aktivno. Meni to je super, ok, ne bude se face. Što je bitno.
Niste vidjeli kako je snimio onaj seća životinje?
Tebi ovo smeta?
Na velesajmu.
No. Ajde, ajmo skup. Sam stol. Ne, pa pomakni fotoaparat. Jesam, pokušao sam da se ovo... Što se otvara? Neđe.
Tako.
Samo varicu još. Znači, sad vidite u našu...
Generalno,
On sam se treba pomaknuti malo u... Smeta, na plan. Ispusti se, ja sam ti pričao. Znači, se vraćamo. Da, sam kad... A ovo više nije sad spaljeno, za početak sigurno. Ali ti na kraju kraja možeš i u Photoshopu, ne mogu se neko reći. Ako se niko ne reći... Makni kameru ili? Da ne, super, neko se reći. Da, dobro, biće dobro da što njemu. Jedan što idu za ove zrake. Kad on sjedne može biti šmoku. A kak si uspio onaj zastor srednji na lijepo? Šta sam ima više tkanine? A jel možemo onda iza njegove glave staviti taj zastor? Ovaj, ne prozir. Hajde, pričaj. Znači srednji zastor da ode na lijevu stranu. A onda iz glave neće zraka izlaziti. Misliš neće? To je donji, onaj ispod njega. Layer ispod, taj. Bravo. Ja, što to nema desno. Aha. Do kraja, vidi se ovaj skroz lijevo. Ispod, ovaj je bitan ispod. Daj mi da ću sad ulicu. Ćemo se otvoriti vrata, da čujemo zveckanje, bar malo sredno. Ajde, otvori.
So asking you questions quickly. This is the video.
Can you please just the...
Sure.
Do you remember the postgraduate course video?
Yeah.
So we want to do something similar.
Okay.
So your part is to talk about why EULAR is supporting the PARE conference, why it's important that patient representatives are educated, what opportunities do you see to further enhance the collaboration between patient organizations and health professionals?
Health professionals, including physicians, or just all of them? So including physicians.
Desno stoji, desno, moraš srednji desno.
And you ask them one by one?
Yes.
Okay.
We need to be
Crisp. No lengthy.
And I think the most important thing is the support mutual collaboration.
Yeah. Well, I mean, power is a member. That is important. They're not outside.
Yeah.
Very important for both sides.
Yeah. So the other interviews are going to be for example, for Christiana, Simon Stones.
Yep.
Sam malo. A ja ću
To promote the
Sure.
Okay. Now we can sit, please.
Can I see?
Of course. And that's good. Nećeš šuškati o... Ne diruje odjeću. A? Kabel će biti zavisi, kad se korist tako razbacano, se može zavisi. Ništa ne možeš se zavisi. Znači, mogu se samo igrati i dobiti vrlo slično. Probao sam, vidio sam, gledao sam koliko lejera nisam. Znači se zavodio sam nakon. You start in a few moments.
wonder this time where he's gone. Wonder if he's gonna stay.
Okay, thank you very much all for coming back. And it's really good to see that after such a long and busy day, the room is still filled till the end. So that's really great. We are now at the last part of the program for today, which is the official program. But of course, we have something nice also for tonight. But I actually hope that you enjoyed the best practice fair. Did you enjoy it? Yeah? I think this is something that we from PARE values, because every time that we ask you, what do you expect from the conference, we get the feedback that you say, we want to share best practices, experiences from other organizations that are member of PARE. And as you probably know, this is what we also did in previous years. Then we called it the poster session. And then we had a kind of, we also had 3 categories and a prize-winning announcement at the gala dinner. But we thought actually that the posters and all the work that you put in the best practice presentations deserve more attention. So this year, for the first time, we will actually also, following the votes that you gave to the posters, present the 3 best practices. So be aware that the persons that will present here did not prepare their presentations because they were not aware whether they would be voted for. So I think it's a great trial, and we will look how it works. And I also would like to encourage you to be active in the discussions that we will have about these 3 best practices. I will announce the 3 winners, and they will also receive a small present. And then give them the floor to briefly introduce their projects. And then we will have a more global discussion. In total, there were 23 submissions. And what we see is that these are not only posters, but also more and more combinations of posters or even only social media, video presentations. And I think that that's really great to see that we are also using these new means to raise awareness about rheumatic diseases. So, are you able and willing to know the winners? Yeah? Okay. In the first category, which was about awareness-raising campaigns for patients, there were 11 submissions, so that's actually also the biggest group. There was 1 including with video, but the winner is, and I have to announce that I did not vote. I did vote in this session, but not on this one. I'm very honest about it, but you will understand also why. But I would like to invite, can we get some trumpets? Ruffles? Good. Okay, I would like Wendy to come forward. Your first time at a conference and immediately prize winning. Wow, this is really a rising star. This is your present. It is from Bulgaria. They choose this for you. And just have a seat and prepare for your short presentation. Okay. Then we had a second category, which was focused on public awareness raising among the general public. And that was one, ruffle again, by the Greek youth group. I would like Anastasia, to come forward. You both come.
Yes, we're a family.
You are a family, okay. So probably this will be a dual.
We're three. We are three. We are T.
1, 2, 3.
She's the photograph.
She's the
photographer. I'm the presenter.
Yeah,
and she's the
we have one place. Okay, come forward. Yeah. Okay, sit. Yeah, you have to sit in one chair. But it doesn't mean that you get 3 presents.
No, only one.
Only one.
Only one for 3.
And you are the first author of the abstract, so I give it to you.
For me, for all Greece.
Okay, congratulations. And then we have the final category, which was about raising awareness among policymakers. And there the winners are, and this was very good. Oh, think about the glasses. Ireland. Sinyat,
Thank you.
congratulations
Thank you.
with a very beautiful campaign.
Thank you.
Okay. Well, that's for the, that's for the photo, and then you can take it a chair. Okay. Well, congratulations all to you. It's great to see that we are very successful also in encouraging young people to enter PARE and become more active. So they should not become too active, because otherwise they will take over. Would that be a bad thing? No, okay, good. I would like to invite Wendy, you first, to introduce your project. Very briefly state maybe what were the objectives, what did you want to convey to patients, and how did you go about? I think it should be pressed somewhere here. Is there a button here?
Hi, everyone. No. Hi. Yeah, now it works. Hi, everyone. I'm Wendy, and I'm from the Netherlands. I'm now the new chair of YouthRL.com. YouthRL.com is the organization for youth in the Netherlands for young people with an RMD for 60 to 30 years old. As you see, our logo here, I don't know if you see it, but it's YouthRL.com. So .com is the most important thing in our organization because that's our online youth platform. We got a lot of questions because we are like already there for 10 years, and because we are a successful organization, we got questions about how we established an online youth platform. And for that, we wrote a guide with our best practices and how we did establish our youth group and our online youth platform. And you can download it if you want, but it contains like all the best tips and tricks to establish an online youth platform. And yeah, everything you need to know is in it, I think. So if you want to start a online youth platform, you should really like read it. It's good. I also have some copies, so if you want, you can get one. Besides the guide, we also had like 2 knowledge transfer programs. I think most of you did heard of it, but we had like 2 programs one with Italy and one with Romania and Poland. We learned them how they could like establish an online youth platform with the use of our guide, and we helped them with the first steps. And I think they are doing a really good job now, so yeah. Yeah, well, I think that's it. about our poster. Thank you.
Thank you very much. I think it's wonderful to see that the EULAR Knowledge Transfer Program, which is a small budget where all PARE members can apply for to set up a project, a collaborative project with another PARE member. And if I see what you have done, and I don't know whether you have seen the booklet that they produced, I think you did a wonderful job with limited resources to be so successful in helping 2 other leagues to set up use groups and also to put it in writing so that others can follow the same example. So that's very worthwhile. Can I ask someone in the room who did vote for this poster and would like to say why you thought this is a good example or a best practice? You?
Hello everybody, I'm Alexandra Matic for Serbia. I give my vote for you, and I think it's a very quality and good presentation or panel, however. And now then I heard that you have a little money or financial, I'm very delighted to give my voice to you. And I have this, and this is very good book for young people and everybody who have a disease. Thank you.
Thank you too.
Okay, thank you very much. I'm just informed by Florian that if anybody is interested in the knowledge transfer program and you want to make use of it, make sure that you get a hard copy of the conditions and how to apply. So this is really something that we value much. So please use it also. It's there, you can use it, and you can benefit from it. Did I put it here? Okay. Someone else who would like to say why you thought this is a best practice? Who did take a copy? Jolanta?
I am Jolanta from Poland, and we participate in knowledge transfer program. Me as president of federation signed this program, and it was really successful for us, and we are preparing a new platform for young people in Poland. And thank you, Wendy, for opportunity to join your workshop, and we can learn a lot. I am not representing of youth rheumatic person from Poland. I was young, but I know how it's important for young people to have a good source of knowledge and supporters, peer supporters. It's very important for all of young people.
Okay. Yeah, thank you. For the people who did take a copy of the booklet, who think that they are going to use it and try to set up a youth group in your country? I see a green card, a hand up. Yeah? Would you like to say a little bit what you expect from the guide?
Guidelines to set up a youth group, I think. Yeah, we discussed this in the workshop too, and I hope that this will provide me with more information and tips on setting up a youth group.
Okay, yeah. If they have questions, where should they go, Wendy?
To youthrl.com. To our.
You are still willing to answer questions?
Yeah, I am.
And to help others out? Yeah?
Yeah.
Okay. You have now done this project, and you have produced the guide. Do you have further plans to evaluate how the guide is helpful, how it can be implemented? Do you have any thoughts about the follow-up?
Not yet, I think, but we could do that.
Yeah?
Yeah.
Okay, would maybe, I know there are some members also from Young PARE in the room. Is there a role for Young PARE to play here? Sorry. Anybody who wants to say a little bit about Young PARE? No? Okay. Well, thank you very much, Wendy. I think it was really terrific what you did. And we hope to hear more from you in the future. Keep on work. Thank you. So now, how did you already solve who is going to present on behalf of the Greek? Dora will.
So, hello, I'm Dora Papastavru. I represent Greece. We are from Hellenic League Against Rheumatism. I'm a new board member also. It's been almost a year that this roller coaster started for us. So we are here. First of all, I would like to say thank you for all of our voters out there and the supporters of the Greek team. We presented the patient rights. We had a poster and also a video. We had an idea to inform the general public with not only RMDs, but generally chronic diseases, that they don't have only responsibilities, they have also rights, patient rights. So we tried to list 10 most important rights for patients in our idea. In our minds. They involve patient confidentiality, medical research, informed consent, human dignity. We tried to list everything. Our poster was very explainable about if you wanted to read every right. And we had an idea that we would make on our own, our video. So we took photographs, many of photos, that are playing like a video under Acropolis in ancient Roman Agora in Athens, the capital city of Greece. So we have a video also. What else?
Okay.
So.
Yeah.
Yes. You want to see it?
Do you want to see it? Well, most of you have already seen it, but we will show a little bit of the video.
thank you for all our voters.
Very beautiful. I think that must have been very costly to make such a video.
No, the video was created on our own. We took the photos. Dora created the video. She chose the music without intellectual property rights. And it was all an idea. And we created the poster. It has nice contrast, you know, it's orange with white background.
So you all did it yourself? All the things?
Yes.
Did you have any help with producing
With the printing of the poster.
Only the printing of the poster?
Yes.
Wow, that's really impressive. But it looks like you also had fun.
Yes, a lot of fun.
It.
Under the Greek sun.
Okay. Excellent. Who did vote for this presentation? Yeah? Would you like, Rieke Alten? Would you like to tell why? Yeah, there is a microphone coming.
Actually, the points you have hit on your poster are so correct and so exactly in the wording that it could never ever have been better expressed.
Thank you.
So we can use it for so many other occasions, and I will transfer, of course, this to Germany and tell my colleagues and also our patients that it is so impressive.
Thank you. We used easy English words that everybody who is not a native speaker can understand in order to convey what we wanted to say about it.
Do you have a similar one with Greek?
Yes.
You do?
Yes.
Okay, yeah. Does anybody of you have questions for Dora or one of the other presenters? What will be the next step? Sorry, Marius, think about this one. Marius first.
So just I want to ask how you intend to implementing all the rights.
We have the Greek poster. We will inform our patient. We will post the video. This is the first time that the video is live. So yeah, we're going to inform our patient and our team organizations. And we will convey that they have rights. And they should ask for them. And
yeah. Did you also collaborate with health professionals?
yes, I had meetings with bioethics because we had the patient right about medical research, that they have rights to be informed and with informed consent. And we were based on the doctors, they have the bylaws or something, the medical. So we were based on their laws too, and then general ideas about what a simple patient should have a right to.
So you did check the liabilities of the things that were in the
yes.
video? Okay.
It is accurate in Greece, 100%.
Yeah. Okay. And it looks like everything went very smoothly, but I can imagine that it didn't, everything did go well. Did you face any barriers in producing this?
No, it was fun. It was
yeah?
We have a small, not difficulty, but it was something that provoked us, I can say, that we should make the list of the rights easily understood to someone who is not a doctor. Because sometimes laws or doctors speak as if we know their terms. And this is my personally, I don't know the word now. Anyway, we've tried to use some easy language. That's what Dora said. This was the most difficult. But
okay. So really the challenge and the efforts to avoid any medical or difficult language. Yeah.
We are a lot of year patients, over 30 years.
So we know, I think we know better from all the doctors. I'm sorry about that, but I am the person that I feel pain. I must speak about my illness.
Okay. In the end, I would like to point out that don't forget, before you're a patient, you are a person.
That's true.
Thank you.
Okay. Well, thank you very much. And a beautiful example of a collaborative project and something really made by patients, for patients, made by people, made for other people. Beautiful. Okay, then our last winner from Ireland. They have been very successful. We know it's a great organization in terms of self-management. But I think you are now telling a little bit more about your campaign.
If I can find it, 1 second. Well, Seasons Restaurant is over there. Oh, here it is. I have it, I found it, thank you. Okay, well, first of all, hi. For any fellow spoonies out there, I'm not sure how many spoons you all have left, but I'm kind of running low. Thank you all for voting for this presentation. My name is Sinead Frawley and I work with Arthritis Ireland. I'm the Regional Development Executive and I help to look after a lot of the branches in Ireland as well as doing things like this, which is fantastic. So I'm just going to run through our campaign. So basically this year in Ireland we have a general election, so we're looking for a new government. So what we decided to do was to run a pre-election campaign asking for all upcoming new people going into government to help us. And the reason behind that is we don't have enough rheumatology services in Ireland. At the moment, there's over 12,500 people on waiting lists in Ireland, including 455 children. We have a system in Ireland that can't cope at the moment with the demand and the need in Ireland. We have 33.5 consultants, rheumatology consultants, whereas we should have 45. 16.4 clinical nurse specialists, again we should have 45. We have 3 advanced nurse practitioners, we should have 15, 12.9 occupational therapists versus 45, and 24 physiotherapists versus 45. The facts in Ireland with arthritis at the moment, 1 in 5 of us in Ireland is living with arthritis. It's the biggest cause of disability in the over 55s. The average age of diagnosis for RA is just 35, and there's 1,000 children in Ireland living with juvenile arthritis. 7 million days are lost in absence due to MSDs costing €295 million in illness benefit. 30% of people in Ireland become permanently disabled within 3 years of an arthritis diagnosis. So what we're asking the people who are going for election in Ireland this year is to support and follow our 100-day plan. And what we're trying to achieve is to cut waiting lists, improve treatment and save money. We ran the campaign primarily on social media using the hashtag #ArthritisChampion. What we're wanting these arthritis champions, who are hopefully, whenever we form a government in Ireland, which we still haven't to this day, we are proposing 100 new rheumatology posts across the 6 hospital areas in the first 100 days of government. And as you can see, those posts aren't in the capital. Those posts are all over the country in rural areas where people are in desperate need of these services. 1 second now. 1 sec. Sorry. Technical difficulties. No, there. Okay, so that's what we're saying. We're asking for a political commitment of 100 people in the first 100 days of government, 6 additional rheumatology consultants, which still won't bring us up to what we need, 29 additional clinical nurse specialists, 12 rheumatology advanced nurse practitioners, and 21 additional physiotherapists and 32 occupational therapists. So what we devised was a toolkit to enable people to contact their local politicians, their local election candidates, and included in that toolkit were the following. So there was this post here where we asked people, we sent it out to everybody on our database, so anybody that ever had anything to do with Arthritis Ireland, anybody that we had ever contact with or contact with us, we sent it to. We sent it to doctors, nurses, the media. We sent it everywhere we possibly could. So we made it very easy for people to ask their local candidates to get involved in several ways. We have a dedicated website that we set up specifically for this election campaign called www.whyarewewaiting.ie. We couldn't have made it easier for the election candidates to sign up to become an arthritis champion, to support our 100-day plan. Literally all they had to do was stand at the door, stand anywhere they could, holding this card that says, I am a #arthritis champion, take a picture of it, post it to their social media accounts or send it to us in Arthritis Ireland, and we would do the rest and try and get these trending. The more the merrier. We wanted to get the word out as much as we could. We had a public launch outside the Dáil in Dublin, Leinster House, which is where all the politicians meet. We stood outside holding our "Why are we waiting?" with a question mark sign. We had volunteers come on the day to help us out. We have the two lovely ladies on the left who are suffering with juvenile arthritis, who came along on the day as well to help us promote it. Here are only a snapshot, I'm happy to say, of the politicians that signed up to become arthritis champions in Ireland. We had 70 politicians sign up to become arthritis champions, which is a huge number in Ireland, I can tell you. Of the 70 politicians that did sign up to become arthritis champions, 37 have been elected to government. So whenever we do manage to elect a government in Ireland, we have 37 of those people committed to implementing our 100-day plan, which is absolutely fantastic. This campaign was mainly done through social media. However, we did have help. We had media support through radio, TV, and various press outlets as well, including newspapers. But I really want to just show you the social media impact that the campaign had. These are just a couple of stats from Facebook 1 week into the campaign. We had totally dedicated our social media to the campaign once the general election was announced. And from the date the general election was announced to the day we went and voted was 3 weeks. So we had 3 weeks from the word go to get as much as possible throughout Ireland as we could backing this campaign. So I'm really happy to say that within the first week into this social media campaign, we now have, well at this stage, nearly 12,000 total page likes on the Arthritis Ireland Facebook account. We had 1,787 reactions to posts that I posted on social media. Our most popular posts reach over 117,000 people. Ireland's a small country. That's an amazing figure. It went so well for us. We had 99 comments in the first week under our post, 258 shares, and 4,862 post clicks. In relation to Twitter then, from February, I've taken stats just from February alone on Twitter. As I said earlier, I nearly had carpal tunnel syndrome because I tweeted 469 tweets in the month of February, purely on this general election campaign. Our tweet impressions reached over 146,000. We had 1,801 profile visits, 482 mentions, and 69 new followers in the month of February, which again for us is huge. So we were extremely happy with that. I've just given you an example of a tweet the type of tweet that we posted. We tried to be emotive in our tweets and tried to reach as many people as we could. So every day on a waiting list is a day of my childhood gone. And we used the #ArthritisChampion and the #100days to try and keep it trending and get momentum for the 3 weeks that we had to make this a success. Thankfully, the #ArthritisChampion started trending. So it was in the top 5 hashtags that were the highest trending hashtags on day 1 of the general election in Ireland. So extremely proud of that. And finally, just a summary slide here just to say we had over 70 election candidates signed up as arthritis champions. 37 of those were elected. And as we await the formation of the new government, we're still trying to form a government in Ireland, we're asking all of those elected to keep their promise to their 100-day plan. We've sent tweets congratulating all of those elected, and we've tweeted those commiserating those who failed to get elected, and the campaign continues. So thank you very much for your time and for voting for us.
Thank you very much.
Welcome.
I think a brilliant example of a best practice of campaigning, specifically for targeting policymakers. And I think one of the strengths of this campaign is really that you were able to make it measurable. Your demands were quite clearly funded by figures, what is needed, and I think that's something that you need if you set up a campaign like this. And you also have some ways of evaluating the campaign. Is there anybody who voted for this campaign who would like to say what you like of this campaign? Yeah?
I was particularly impressed by the fact that you've got so many politicians running up into an election to commit to something they'll do afterwards. More often than not, I find politicians are try to avoid anything outside of their normal policy of the party running into an election. And I just have to applaud you for that.
Thank you. It wasn't easy.
But do you also mean that it's easy for politicians to sign up also in advance of the elections? But how are you going to follow up and make sure that what they promised, what they say?
You haven't met me.
No, do you need, the campaign continues.
The campaign continues. So unfortunately,
that's the hard bit of it.
It is the hard bit, because unfortunately we are in a position where we may actually have to run this campaign again. We're looking in Ireland at the moment at having another general election because we've been unable to elect a government. I think it's 49 days now into trying to elect a government. So we may have to start all of this again, but the good thing is that it's measurable, and the good thing that going forward, if we do have to do it all again, we have the commitment from those that have already been elected, so that takes the big sting out of having to run it again, you know. So it will be a challenge, but you know, we're happy to do it. I mean, it's successful, it's tangible, it's something that we can measure, and going forward, I suppose, like Raj was saying there, you know, we can't make people. Yes, they've promised to sign up for they've promised, you know, to commit to this 100-day plan. But what we will do is have a continual channel of communication with these people via social media, via letters, via every possible way that we can to make sure that they keep their promise, their 100-day promise.
Yeah, okay. Any other questions? John.
Thanks, John.
Don't worry, Sinead, I'm not going to put you on the spot, but I'm just thinking, like, we're here in Sofia in Bulgaria, and like for the first time I've learned the services here for people with arthritis are pretty poor in terms of access, and you know, we couldn't have done this campaign without the input and the support of all the rheumatology community within Ireland. So all the numbers stack up, all the numbers are real numbers, and the Irish Society for Rheumatology fed into it, the nurse specialists fed into it, so they're all their numbers, and we're just campaigning on their behalf. So, you know, if I was starting all over again in Bulgaria, I would probably look at doing something similar to this, you know, to help the rheumatology community get more resources and therefore form tighter relationships with them in the future. Just a thought.
Yeah, so you mean that's one of the most important conditions, collaboration with the health professionals, also to back up the data that you use. Another key element in this one, and as you probably, some of you know, I'm a Twitterer from today onwards. But how important were the social media? Because I can see that it's becoming more important compared to other ways, like you said, written posts. Are you still writing letters to parliamentary candidates?
Yes, so the social media was a huge element towards our campaign. A lot of the people that we wanted involved were news outlets, media outlets, politicians, to try and get the information to as wide a network of people as possible. But yes, we did write letters to politicians, we wrote emails, we wrote everything, in every channel of communication that we could possibly think of. We utilised that. But I suppose the reason that I used the social media element of it here is because it was so successful for us, as opposed to, let's say, the traditional methods of communication. And because I suppose we got trending. And I don't think that's happened to us before. And it was just an amazing achievement for an arthritis organisation to be trending for #ArthritisChampion, and it just was such a sense of achievement to the whole organisation in Ireland, who put blood, sweat and tears into this campaign on behalf of everybody in Ireland living and waiting on waiting lists, and the nearly 500 children living in pain on waiting lists. So we just really tried to use every form of communication possible to get out to as many people as we could.
Thank you.
Thank you. Thanks.
We come to the end of this last session. I hope you enjoyed it. At least I really appreciated and enjoyed all your 3 presentations. I think, although I know that in most groups it was really a tight competition with the others, all submitters did get votes, so I think that's. And I personally thought that all these submissions and posters were really of high quality. So I still remember, and this is some years ago, where sometimes there were posters still printed on an A3 at home. Maybe some of you remember that. But this time, I think really all posters were of high quality. But yours were voted as best. So congratulations. Thanks for presenting it here. So that's a big applause. Thank you all also for attending, paying attention to the posters, and giving your votes. And maybe, do you still have your voting cards? Yeah? I would like to ask you, do you think this way of presenting the winners of the best practice, do you like this format? So it seems there is a reason to consider this for next year. Okay, thank you very much. Then I would like to go back to Florian, who has followed the Twitter wall.
Thank you. I just would like to thank everyone here in the room who's also contributed to the 1,230 posts that currently are on our list, and it's still growing because obviously people are reacting now to discussions that have taken place. Collaboration is key in any of the aspects that have been mentioned, and we've seen that it can achieve great results. And maybe as a suggestion, because I've seen that you would like EULAR to take some role in teaching social media, and Martin is becoming a teacher maybe himself soon. And in order to grow the community that listens to the discussions, maybe you can take 1 or 2 posts that you liked specifically and send it to one dedicated account or person or organization that you have not involved maybe until now in the Twitter discussion, so you can involve that organization that you would like to address, or the person, with the hashtag PARE 2016, and maybe also hashtag shared decision making. And if you want to add person-centered care, the more the better, in order to include more in different topics at the same time on Twitter. Thank you very much.
Thank you, Florian, for following everything what's happening on Twitter. as you probably remember, it seems so long ago, but I think it was Dieter who started with some housekeeping rules, and we are now going with some housekeeping rules and looking forward to the next parts of the conference. So, we are coming to an end, as said. You will have now some time to rest. So, you can go to your room or do something else, go outside. But then there is a possibility to join us before dinner at a small kind of reception, but it is just optional. So it looks like it's wine and rosé thing, but there probably are also other drinks. So this is really optional, but the dinner will be from 7:30, and we really hope to welcome you all. And then there will be another day tomorrow. And I think there will be breakfast, and for the exact times, please look in your program. There is yoga between 8 and 8:30 for those who are interested in that. And this is important for you to realize, that tomorrow we will have 2 rounds of workshops. So we do not start with a plenary session in this room. So you are all asked to have a look at the different workshops. You have been allocated 2 workshops. And here you can see the room that you have to be in. There are 2 workshops that also will be streamed, and these take place in this room. So these are 6A, the first one about transition, and then in the second one about patient-doctor communication in the 7B workshop. So there will be no guidance. You are really expected to go immediately to that room. There will be a coffee break between the 2 sessions, and after the coffee breaks, you also immediately go to your own room. And then, will there be a next one? I don't think so. Yeah. So that's the afternoon, but this will be introduced to you also tomorrow. There will be again a feedback, reporting back session, and a closing of the conference. And then for those who assigned and show their interest at the reception, there will be the excursion. And in the evening, we will have the gala dinner outside of the hotel. Are there any questions? If not, then have a good rest and a well-deserved rest, and look forward to you later this evening.